if the first exam didn't go as planned, you can't know how hot the water is until you dip your toe in it. So if it was hot, which it tends to be, you get used to it, right? So there's no way of knowing until you try it out. So if it didn't go as planned, use it as a learning experience. Use what worked for you. If something didn't work, just mix it up. I think one of the biggest, if not the biggest thing about med school is learning how you learn best, right? Because everybody's different. So much of the first term is a lot of trial and error, trying to figure out time frames. When you do you do questions? How do you post read? Do you pre-read? It's all about that. So it's a lot of trial and error, but that's why it's set up this way. So the agenda right now, I'm going to run through the 3 weeks material with you guys, kind of point out the high yield stuff. Then Lindsey's going to do some cumulative questions. We'll probably take a break in the middle. This is very informal, so if you're confused or something, just speak up and we'll cover it up.
If you have questions, just put them in the Zoom chat. You can private message Brady or I, but put it to everybody so everybody has a chance to read your question and then answer your question, because of course peer-to-peer learning is really good, and that'll help you guys out. So
you can slide in my DMs. I ain't mad. All right. A few housekeeping things first. Let's see. So look, if you go to the Scrubs page, these are the slides for today. But if you're looking for the channel links, right, these are going to come in handy going forward. There is, so it's private. So if you subscribe, you won't see the videos. But there's a link over here to the playlist, term 1 and term 2. So if you click the link and bookmark it, it'll bring you to the playlist. Everything's here that we've done. If you want to look ahead at some of the stuff, I mean, just focus on your stuff right now. But in the future, if you want to look ahead, all of the reviews for term 1 that we've done are here. So you could do that. So just bookmark it so you can find it and you'll be good to go. All right. And as I said earlier, these slides are posted. So I know a lot of people like to annotate as we go. Lindsey's questions are not posted because she doesn't want y'all looking at the answers beforehand, because y'all would, right? We don't like that. So, oh yes, and also, so as we go along, our reviews become much more conceptual and less question-based, but because you're getting used to this platform, this way of answering questions, we'd like to do it very much question-based, so we can walk you through our mindsets when we do this. But understand, I think I mentioned this before, these questions are just like sports, right? Just like practicing your jump shot. Like the more questions you do, the better you get. The faster you get, the more efficient you get, the more confidence you have. There's an art to doing these questions. You need to figure out what works, highlight, strike out, try to point things out. There are no all of the above, there are no A and B. So there's one best answer. So as you get going with this, you will get better with that. But by all means, take that as a learning experience, because the best correlation to how well you're going to do on the exams is how many questions you do. All of us like to put them till last because we like to get through the material and then answer the questions correctly. Sometimes it's just not feasible. You need to, you need to, even if you're getting the questions wrong, at least when you finish them, you're learning from them. So that's the whole goal, right? So as long as you can go through, figure out why some answers are wrong, why the ones are wrong, and why the one that was chosen was right. Okay, so even if you're not 100% confident with the material, you need to do questions as you go. All right, I run Scrubs. Lindsey runs Dog Mom. Y'all need to use this, okay? We put on our Google Drives, this is high yield. We put on our Google Drives a bunch of stuff that we found helpful through the terms. This includes extra questions, charts, tables, hundreds of hours of material that we didn't even get to. But if somebody gave us something, we put it in a folder. So go through, find the stuff that y'all like. But by all means, go look at it. We do this for all of the terms. So stuff's there. If nothing else, the extra questions, the old IEA questions and stuff are on there. So I'll definitely take a look at that. All right, so I remember very vividly, Lindsey and I were still on the island at the time. After our first FTM1 exam, we're like half hungover going into this first lecture for FTM2, just kind of like, we're like, whatever. And then Dr. Sobering starts rattling off a bunch of math. And we're just like, why are we even here right now? So if you need to go back and look at this stuff, he did post, these are the links to those videos. The school understands you don't have scratch paper right now, so they make these equations fairly straightforward. You know, they're not going to give you anything crazy because obviously you can't do the pedigrees. So there's pros and cons to that, but the big pro is that you should be able to do it in your head, okay? So the practice questions we have set up are going to be ones you can do in your head. So we're going to run through some of the tricks for that too. But if you want to look at these links are there. All right, so there's a little bit of difference because when you do the Henderson-Hasselbalch equation, or no, that's the wrong one. When you do the population genetics questions, we did that with the other term yesterday. You have an allele frequency and you also have a phenotypic frequency, right? So even though some of the phenotypes will show up, like MM would be homozygous normal, NN would be homozygous recessive, MN will be your heterozygous, right? So this is how it would break down with the P squared plus 2PQ plus Q squared, right? This is how it's going to break down. But if you actually break down the alleles, the dominant allele is going to be 80% to 20%. I just put this in here because that's how Dr. Sobering has it set up, but it's just to make sure you understand that the genotypic frequency, the genotypic frequency over here is different than the phenotypic frequency a lot. So I'm going to run through quickly how these equations work out, but I do have a blue slide with all of just the breakdown, like it's just like what you need to know. So I'm going to do it quickly just so y'all can see how it works out. All right, so this is the equation we're going to use. P squared is going to be our homozygous normal, 2PQ is going to be our heterozygous, Q squared is going to be our recessive, homozygous recessive, right? This is from first aid. If you're not using first aid yet, the sooner the better. If you want to know what's high yield, first aid is the place to go. All right, now, we mentioned this already. This is going to work out to our homozygous normal, heterozygous, and our homozygous recessive. So between this equation and the P plus Q equals 1 equation, we should be able to figure out everything. If you tell me what one of the values is, either the homozygous normal value if you tell me the homozygous allele or the recessive allele, either the big A or the little a, I can tell you the whole breakdown, right? All you need is one value to figure out the rest. Because if you have P and you know that P plus Q equals 1, you can obviously figure out Q. So you can figure out everything. So that's the whole goal. All right. So when we look at the recessive allele, obviously we're just looking at Q squared. Again, this is just how this math breaks down, but there is a slide that just has everything you need to know for the exam. So obviously we're only looking at this. So if you know the incidence, right, the incidence in the population, how many people in the population are homozygous recessive, the incidence breaks down to Q squared equals the incidence, right? So if you change the math around, Q equals square root of I. The autosomal recessive equation for this is going to be the most important, just because it's just the best way to break down the test. Like, but by far the most pedigree questions you're going to get from Dr. Sobering are going to be autosomal recessive. So this is the equation. It just works out better in your head and without scratch paper. So this has been traditionally what they use, the autosomal recessive ones. All right, but we're going to go through them all anyway. And I put a lot of these extra slides. You can go back and read these, but it's kind of what I'm talking about as we go. All right, so the recessive carriers are obviously going to be our 2PQ. So if we break that down to incidence, the incidence is going to be 1/2 times I, okay? And that's just because I just changed the values around. All right, autosomal dominant. So we are looking at 2PQ plus Q squared. Here we're using Q squared for the incidence, right? So you technically could use P squared as your autosomal dominant, but we tend to use the diseased frequency as Q, right? It works out either way, but Dr. Sobering has it this way. So again, the autosomal dominant is going to come out to Q equals 1/2 times I, which looks very familiar to what we were just looking at. But it depends what they tell you the disease is, which is going to be super important, and we're going to point that out. We have little mnemonics for remembering what diseases fall into what category. So we'll look at that in a second. And this is what Dr. Sobering had. X-linked recessive. So, you know, men are hemizygous, right? Because they only have one spot for the X, that means if they get the diseased X, they're going to have the disease. That's called hemizygous, right? Whereas women have a 50% chance, two X's. So 50%, well, excuse me, they could be carriers, right? It's very infrequent that they would actually have an X-linked recessive disease. They would have to get it one X from mom and one X from dad, right? So much more likely, women will be carriers, men will have the disease, okay? So men are hemizygous, so we can actually break it down using the P plus Q equals 1 equation. So Q would equal I, Q being the recessive, or the X with the mutation on it, right? All right, X-linked recessive, use 2PQ to figure this one out. And again, this would be for female carriers. So there's a 1/2 chance in the incidence that they would be carriers. All right, I'm going through this quickly just because I have this slide here. This is all you need to know for the exam, all right? As I said, the autosomal recessive one is the one you're gonna use most often. That's how our questions are set up. It's just much easier when you, and much more tested for whatever reason. So that's what you really need to focus on. All right, so as long as you know these, you should be good to go. But again, for all intents and purposes, you're just going to use this autosomal recessive one. All right, I don't believe you have to memorize this, but this is just, it's kind of like there's always a little extra information in the question. So if you go the extra mile and you learn a few things, in addition, sometimes that little extra material can help clue you in if you're lacking in another area. So you can see these genetic populations fall, or these genetic diseases fall in certain populations just because of the where they live and you know, the genotypic makeup of the area. All right, so this is our super important equation that we're going to use. So when we're determining this, we want to figure out the dad's frequency times the mom's frequency times whatever the disease is, be it autosomal recessive or whatever. All right, this is another blue slide. The reason I like this, because since you don't have scratch paper, you can use these rules. You need to use these rules, okay? So the questions will very blatantly have certain situations, and you know immediately without doing a Punnett square or anything, where you fall in these categories, okay? So the 2/3 rule, if you have a sibling that has the disease, right? And autosomal recessive, again, this is what we're going to be focusing on mostly. You have a 2/3 risk of being a carrier, all right? Now, this is the 2/3 rule, meaning that you've been born, right? Like, we're not saying that we don't know the genotype of the fetus, right? So we could say that the sister of or brother of the person with the disease has a 2/3 risk. The reason it's out of 3 and not out of 4 is because you can definitively say that that child doesn't have the disease. Okay, we looked at this last time when we did it before. So if you look, let me just show y'all. So if we do the Punnett square and it's autosomal recessive, right? So we know that one child actually, so 1/4 chance, right? So we know that the first child has the disease, right? So they fell into this category. We have a second child, we can say that this child doesn't have the disease. So we're saying, what are the chances that the child is a carrier? Well, it's a 2/3 chance, 2 out of 3, 1/3 chance they're normal, right? So the point is that when you, and I have a question coming up about it, when you see this immediately, you know that that risk is 2/3. Okay, you don't need to do the Punnett square, you can just say that, and that's going to help you on the exam, speeding up your time. So there's also the 1/2 rule. If there's a sibling that has the disease, you have a 1/2 chance of being a carrier, okay? And I'll show y'all that too in the question coming up. Here it is. All right, go ahead and try this one. So again, you want to figure out the father's frequency, the mom's frequency, and then what is the frequency in the population. All right. So let's work this one out. Okay, so first step, and this is always going to be the first step, is cystic fibrosis. What is the, well, let's do it this way first. Okay, we'll do dad, then mom, and then the Mendelian frequency. All right, so here's the first trick, right? Husband has a brother that has a daughter with cystic fibrosis. Okay, so if we go back real quick, this 1/2 rule, if you have a sibling that has a child with the disease, so you're the uncle or aunt to this child, right? You have a 1/2 risk of being a carrier. You can do the pedigree out, you can figure it out, but the math works out that you'll be the 1/2 chance. So you're looking at this uncle here. So the husband has a brother that has a daughter. So the husband that we're talking about is the uncle, right? Because his brother has a child with the disease. All right, so these are the kind of things you need to see. As soon as you see that, you're like, all right, cool, 1/2 rule, right? Because the, so anyway, right, so that we know that's the 1/2 rule. So the husband is gonna have a 1/2 chance of being a carrier, right? And you always wanna figure out the carrier frequency. You're not trying to figure out the disease frequency. And I'll show y'all that when we actually do the math coming up. All right, so we know dad's 1/2. Now the wife has a sister with cystic fibrosis, okay? So if we look back, if you have a sibling with the disease, you have the 2/3 risk. All right, so we know mom's frequency here is 2/3, right? All right, and then what is cystic fibrosis? It's an autosomal recessive disease. So we know that the Mendelian frequency is gonna be 1/4, right? Each child you have a 1/4 chance that that child's gonna have the disease, okay? All right, so we do the math out. Dad's, oh, excuse me, mom's 2/3, dad's 1/2. The Mendelian frequency is 1/4. So the correct answer is 112. Now, the point here is that you don't have scratch paper, so these are the kind of questions you're going to get. They will expect you to immediately be like, that's 1/2, that's 2/3, that works out that way. Mendelian frequency. And then, as I said, it's primarily going to be autosomal recessive. Okay. So if you need to work out the pedigree for the uncle, you can work it out. Just make sure you multiply through the dad and through the uncle, but you end up having a 1/2 chance. So watch. Okay, actually, I'll just do it for you guys. So husband has a brother who has a child with the disease, right? We know it's autosomal recessive. So what is the dad? Each parent has to be a carrier, right? So we know dad and mom are both carriers. So again, when we do these rules, we're looking for the carrier frequency, not the disease frequency. So we know, because this is the husband in question, this is his brother, right? We know the brother is a 1. He's definitely a carrier because the child has an autosomal recessive disease. So if this parent, or excuse me, if this brother we're talking about, they obviously have the same parents, they're going to share half of their DNA, right? So this, so the husband in question has a 1/2 chance of having the same as the brother. So you don't need to do this on the test. I'm just showing y'all how it worked out. So that is the 1/2 rule. So when you do these questions, again, it's just fast when you could see find the uncle or aunt, right? They're 1/2. If you have a person that actually has the disease and they have a sibling, they're 2/3. All right, cool. All right, try this one. So be methodical about it. Mom, dad, Mendelian frequency. All right. So what's the mom? She has a niece who is a known carrier. Oops, I made this harder than it should have been. Okay, so teaching point here. This is not the 1/2 rule, is it? Right, because the niece is a known carrier. So so you can't use that rule. If the niece had the disease, you could use the 1/2 rule. So you actually, so I don't know that they make it this difficult for you guys on the exam, but I'll just show y'all how it works out. So niece, this is the person, woman in question. So if the niece is a carrier, let's see, they would be 1. No, they would be 1. The parent would be 1/2. And then the aunt would be 1/2. So you would multiply 1/2 times 1/2. This is more of a question. If y'all had scratch paper, I would say it's fair. Point being, okay, so this child that we're talking about is a carrier. All right, it's good to know this anyway. And I'm sure if you watch Dr. Sobring's lectures, he would talk about this. So we know definitively the child's a carrier. So there's a 1/2 chance this child got this carrier mutation from dad, and 1/2 chance they got that carrier mutation from mom, right? And then, like we said, when we talk about siblings, they share 1/2 of their DNA. So then you multiply through 1 times 1/2 times 1/2 is 1/4, okay? So that's mom's frequency is 1/4. Eraser, let's see. Now, the more important thing I want you to get out of this is how we're going to work out the incidence, because there's a thing I would just always forget to do this when I did these. So I want to make sure y'all do it right. All right. So we know, okay, well, let's do the frequency first. We're talking about cystic fibrosis again, right? So autosomal recessive. All right, so that's going to be 1/4. Okay, so what did we say about the incidence, right? So it's autosomal recessive. So we said incidence, remember that blue slide, equals the square root of I. I'm sorry, Q equals the square root of I. Right, we said Q will equal the square root of I. Now that's incidence of the disease, not incidence of the carrier, right? So what do we need to do? So we know dad's frequency, Q, is going to be square root of I. So Q is going to equal the square root of 3,600. What does that come out to? 1/60. 60. All right. Right, 36, yes, 60, 6 times 6. Okay, yes. Okay, now here's the thing that I always forget. This is the chance that the father has the disease. You have to figure out the carrier frequency. So what you have to do next, and you always have to do this, is you have to multiply by 2 times the Q, right? Because you want to find out if he's a carrier. I'm sorry, not times the Q. You want to Q is going to equal, right? So what it ends up coming out to, actually technically it is Q times 2. So you end up multiplying the carrier frequency will equal 2/60, 2Q. Because Q equals 1/60, and you want to know what 2Q is. So it's 2/60, which equals 1/30. So that's the chance he is a carrier. Okay, so you take the square root of it and then you multiply by 2. And since 60 is in the denominator, basically cut it in half. All right, I'll just show y'all that again. I hope I didn't confuse anybody. Right, so 1/60 is the chance that he has the disease, but you want to figure, and so that's the answer for Q, but you want to figure out 2Q, all right? So multiply Q times 2, which equals 2/60, which equals 1/30, okay? They will put the answer with the wrong, with the wrong math on there, right? Because they know people forget to do this. So dad's frequency is 1/30. All right, so now we have our numbers. 1/4 times 1/4 times 1/30. Okay, and that's how it works out. So just remember, when you find the incidence, that's actually the incidence of the disease. That's what they do statistically. They find the incidence of the disease, but we're always looking for the carrier. So the carrier is going to be 2 times that, whatever that Q value you get. All right, try this one. We had an exam this week and did on almost 6-hour review with the January class yesterday. So we're like strung out right now, but we're gonna get through it. All right, so these numbers are the alleles, right? So treat it that way. All right, so basically we're asking, what are the chances that this child will get both the DR3 and DR4 alleles? So we're basically treating this as an autosomal recessive equation, right? So if you see here, there's a 50% chance that this boy will get that allele from mom, the D4, 50% chance he gets 4, 50% chance he gets 8. Over here, you see the same thing, 50% chance that this girl or this woman gets the DR3 from mom, right? So the other side is going to be dedicated to dad over here and dad. And so it's 50-50, right? So 1/2 on this side, 1/2 on this side. We know this is 1/4, right? So actually you don't need to do that here. I'll show you. And it comes out to 1/16, right? So you know that the 1/4 correlates to the autosomal recessive, meaning you would need both the DR4 and DR3 to have this this genotypic setup, right? So 1/2 times 1/2 times 1/4 is 1/16. So the same principle, right? say dad's frequency times mom's frequency times the Mendelian frequency. Okay, so this is just kind of broken down. It's the same way of saying like, what are the odds this child gets cystic fibrosis if, you know, because we're looking at the allele frequencies. Okay, I think I pulled this out of, oh yeah, there. That's like first aids question. They use USMLE RX. All right, try this one. All right, so allele frequency. So we can treat this as Q, right? Q is our allele we're talking about. So if Q equals 1 in 400, what are they asking? What is the frequency for homozygotes, right? So we could just choose Q squared. Okay, so Q squared is going to work out to, yeah. Okay, so that is the possibility that a person that has the allele, right, it's a carrier that is 1 in 400 meets another carrier that's 1 in 400, and they end up having a child, right? So the allele frequency of homozygotes. Now, what if we were looking for a carrier there? How would we treat this if we know this is our Q? Well, if we know Q is 400 and we're looking for the carrier frequency, we multiply that Q times 2, all right? So that should look familiar. That's how we do our incidence when we're looking for the carrier. We find Q and we multiply it by 2. Because again, Q is going to be the allele frequency, multiply it by 2, and we find our carrier frequency, okay? All right, so I think that's about as difficult as they can make them for you guys on the exam. So the more questions you do, the better you get at those. But you won't have to like figure out multi-generational pedigrees. It'll just be fairly straightforward. Use the 2 rules to figure it out. We're going to move on and do some other stuff. Hopefully, you have seen this in undergrad. So it's just jogging your memory, but this is actually a difficult question regarding it. But let's talk about the lac operon.
Hey, Brady, we have a few people that are confused on the last question.
Yeah, sure. Right. So, what was the problem? So if we do our equation, P, that's not a P. Right, so P squared plus 2PQ plus Q squared equals 1. We say our allele frequency is 1 in 400. So we're telling you what the genotype is. We're asking you what the phenotypes are, okay? So we're asking for homozygotes. Now, technically, it could be homozygote normal, but we generally talk about this frequency as the recessive trait. So if we know 1 in 400, 1 over 400 equals Q, okay? We're just going to use our equation to figure it out. So if you remember from before, we said that if we're looking for homozygotes, we can use Q squared, okay? So 1 in 400 squared comes out to this, 160,000. Now, if I told you, well, what is the allele frequency, we would use 2PQ. So where we just put in 1 in 400 for Q, we know, maybe this is why, we know P would cancel out, okay? Because P is close to 1. That's just how Dr. Sobring does it. So we use 2Q to find our carrier frequency. So 2Q, I'm sorry, so you fill in, you put Q here. So 2Q, 2 times 1 over 400 equals 1 over 200, right? So you're just putting the 1 in 400 in for Q. So if they give you the allele, they're telling you what the genotype is, and they can ask you any combination of what the phenotype is. Y'all could, if y'all still have questions, y'all could just talk. It's not a big deal.
I hear. I'll just ask it because it's easier. All right. So yeah, I was just the only thing I was confused about. I guess mostly confused when they ask a question, like in the question stem. What this one is asking, like, what is the frequency of homozygotes? So I guess I always should remember that it's the asking about the Q squared in this case, because I don't know why I usually just go straight to calculating the carrier and I like forget to.
Yeah, you have to watch out for that. So this I kind of put this question because it works backwards, right? Usually they'll tell you this frequency and you have to figure out Q. But this way they're giving you the genotype and they're asking you what are the phenotypes. Now you may say, well, why would you use 1 as PQ? Because technically P is 399 over 400, right? Because we know P plus Q equals 1. So if we know Q is 1 in 400, or the recessive type, we know P is going to be very close to 1. So for all intents and purposes, you can cancel that out. So that's why we canceled the P out here. So we use 2Q. But so this is very similar. Remember when we do the incidence, like I want to make a point of this. The incidence is going to be, or when we do those autosomal recessive, the Q is going to be the square root of the incidence, right? When we did it, that's like what we did the 3600. The incidence was 3600. So what is the rate of the carrier? This is the previous question. So square root of 3600 is 60. Now that's going to be Q, but we want Q equals 60, but we want 2Q equals what? So we say 2 times 1 over 60 equals 1 over 30. Okay, so just don't forget to multiply by 2.
Okay, makes sense. Thank you.
All right, no worries.
Also, quick question. Dr. Sobring during one of his office hours said that whenever Q is less than 5% or equal to 5%, we can assume that, like you just said clearly, that P equal 1. So that he really agreed into that during the office hours. Just want to say that. Yeah,
and it's rare. It's never close to 5%. Like 399 over 400 is well less than 1%. Yeah, it's not even going to be. It's not even worth even trying to calculate it out. Like I've never seen a question where like that's not a valid point, where you actually have to figure out the P and the Q. Like it always works out that way because the recessive traits, that we use are so rare in the population. All right, cool. So let's talk about the lac operon. Okay, so I'll give y'all a second. And if this is a little tricky, I forget where I pulled this question from, but I'm going to go and explain how this works, and then we'll come back to the question in a second. All right, so the answer is A, but let's talk about it first. So the lac operon is this twofold method of for the body to be efficient when it's metabolizing lactose and glucose. So the point being, these protein products, Z, Y, and A, you only want to produce them when you want to metabolize lactose, okay? So you want to make them only when you have lactose, but also only in the absence of glucose, all right? If you have glucose, there's no point in metabolizing lactose, all right? Glucose takes priority. So if you have glucose, you don't want to transcribe these, or if you don't have lactose at all, well, what's the point? There's no lactose. So this is like a twofold method of just the body being able to recognize what's the priorities here, okay? So again, if you have glucose, you don't want to transcribe these because there's no point, because you don't want to metabolize lactose in the presence of glucose. Glucose has priority. Also, if you don't have any lactose present, there's no point in transcribing them either, okay? So if either of those two parameters fail, then you're not going to transcribe it. So this lac repressor here, this lac I, is going to be basically going to tell you to stop, okay? So if there's no lactose present, this is just by default. There's no lactose present, you're going to bind here to the lac operator, and you're basically going to say, listen, we're not transcribing, there's no lactose here. Now, let's assume there is lactose. Then if lactose is present, it's converted to allolactose. And in that sense, it will actually bind to this repressor so that it won't activate this stop operator, okay? So if lactose is present, instead of this binding here, lactose is gonna be able to bind to the operator to stop it, right? So it's not going to bind there. So now in the presence of lactose, you're actually going to transcribe lac Z, Y, and A, okay? And that's the idea. Now the second pathway, if there's no glucose present, which is what we would want in the case of transcribing these, this CAMP is going to bind to the CRP, okay? They changed the name of this back in the day, but anyway, does anybody know what this stands for? Anyway, yeah, so it's going to bind to it, and so if there's no glucose present, the CAMP's going to bind, and it's going to bind to the promoter region. Now the promoter region is going to say to transcribe, okay? So if there is glucose present, this CRP is not going to be able to bind to CAMP, okay? And then it's not going to bind to the promoter region. All right, so and this is kind of the baseline. So let's go back. All right, so how are we going to transcribe this? We need to have lactose present. Okay, so let's say this is bound. So lactose is present. So this is out. We're not going to stop it. But also we need no glucose. So I'm just going to draw it in here. That CRP, right? If there's no glucose present, this CAMP molecule is going to bind to this CRP, and then this is going to bind to the promoter region. So now it's going to say there's no glucose present. We get a check mark there. All right. So we are not going to stop it, and we're also going to promote it. Okay. So it's a twofold process. And if you want it down and dirty, this is how it breaks down, right? So you could just memorize this. But the point being is the only time you're going to transcribe is if glucose is absent and lactose is present. Okay. So if we look back at this problem, we want to figure out what's going on that's messed up, right? Okay. Is this correct? Containing glucose and lactose, beta galactosidase was made. Should that happen? No, right? Why are we transcribing this if glucose is present? Okay. However, no protein products are produced when E. coli is grown with only glucose. Okay. So you're saying there's no lactose here. So it looks like the problem is up here. Why are we transcribing beta galactosidase with glucose present? So what that tells you is there's a problem in the process of that CAMP binding to that CRP, right? So of the ones chosen, maybe this is the problem, the CAMP receptor here. Meaning when you look at this process, in the presence of glucose, this should not bind, right? This should not activate this transcription because glucose is present. But because this receptor is mutated, this binds anyway, even in the presence of glucose. Therefore, it's being transcribed. Now, this is a more difficult question than y'all will probably get, but it kind of touches on all the concepts of it, okay?
I have a quick question, Brady.
Yeah, sure.
So isn't it, so if there isn't any glucose, I mean, if there is glucose, and there is lactose present, wasn't there like a slide where it said that you would need, there would be some basal transcription as well, like?
Yeah, I think technically there's, and that's what's so confusing about medicine. There's no black and white. There's always exceptions, but in regards to testing purposes, they use it as a definitive, as check marks. Yeah. So technically,
for
yeah,
our
there's
exam, so like we just assume that if there is glucose present, then it shouldn't be like working.
Yeah, just use the rules like this. Yeah, like I didn't make this question up. This is from some sort of USMLE based question. So yeah, you would definitely assume that for sure. All right, so again, the lac repressor, if there's no lactose, is going to bind, so you don't transcribe this. If lactose is present, it is not going to bind, so it allows it. If no glucose is present, the promoter is going to bind and to make it transcribe. Okay, so if there's lactose present, you're not going to bind the repressor. If there's no glucose present, you're going to bind the activator. So you need both processes to activate. All right, this one's a little more straightforward.
Brady, can I ask you a
Yes.
question?
Yeah, sure.
In order to activate CRP, you need cyclic AMP, but cyclic AMP is only there if there's low glucose, right?
Correct.
So how does it, I don't know if I missed this, but like how does the CRP protein end up being activated if
Right,
there's like
so
a relationship between glucose and cyclic
yeah,
AMP?
sure. I don't actually know any like in detail, but if glucose is present, it must metabolize CAMP, right? So that this will not bind here. There must be some sort of pathway, maybe it's the GS pathway. I don't even know if y'all got there yet, but it must metabolize CAMP in order so that this won't bind. So with no glucose present, then this CAMP is going to be available to bind here, and this will allow for promotion and transcription of this. Yeah, I don't know what actually happens to the CAMP when glucose is present, but for whatever reason, it's not available to bind. Yeah. Does that make sense?
Yeah, I was just trying to understand how it was the receptor protein.
Yeah, so what we were saying is even in the presence, for that question, yeah, even in the presence of glucose, the CAMP receptor was able to bind here. So maybe the glucose molecule could even bind here to prevent CAMP from binding. Let me see, I can, hold on one second. There was like this long explanation for it. I could just put it in the chat real quick. I'll have to post it when I post the with Lindsey's slides. I'll post the explanation with it too. It's really long. Let me see something
Yeah,
real quick.
just after, that's totally fine. I don't want to take up more time. Thank you.
Okay, yeah. All right, when y'all are doing it, I'll try to read through it when y'all do the next question. Let's see. All right, try this one. Oh, okay. Yeah, so this is why. So actually glucose, like I said the first time, so what it does is glucose will actually eat up the CAMP, right? The cyclic AMP. And because this repressor is mutated, it is just turned on. Is constitutively active is what it says, right? So because the receptor is mutated, it's always going to be on, regardless if CAMP is present or not. So that's why the presence or absence of glucose has no bearing on whether it works or not. Yeah, that's a difficult question. I just had pulled it out of one of the review books. So.
No, that's perfect. That makes perfect sense.
Yeah.
No, thank you. Thanks so much.
No worries. All right. So we know this Myc-max complex is what's going to go with the transcription, is going to go make euchromatin or be transcriptionally active, right? Myc-Myc doesn't combine. Max-max is the homodimer that's going to combine if we do not transcribe, right? But that Myc-max complex is what we're looking for. So again, this max-max that's binding is a homodimer. You're not going to get transcription. But if that Myc-max binds, you're going to get heterodimer and you get cellular proliferation. All right, y'all would know this. I was just getting started with this, but this is a huge topic that y'all are going to go through in great detail. All right, so to me, it looks like an upside down butterfly, right? So always remember the dorsal side, the dorsal horn, that's going to be your sensory side. The ventral horn is going to control your motor side. So again, it kind of looks like an upside down butterfly. You see the crease is typically on the white matter here, and the ventral horns are going to control your motor fibers. All right, they have those alpha motor neurons. They kind of look like, I don't know, like little amoebas, sort of like this. But I don't know if y'all have gotten to that yet, but y'all will see that, because sometimes they'll give you a histology slide, and they'll be like, what area of the brainstem or excuse me, of the spinal cord are you in? And you'll see these big alpha motor nuclei, and you only find those in the ventral horn because they control the motor aspect of things. All right, try this one. All right, so I think the trick here is determining if you're looking at the transverse component or the lateral component. So the way I do this is if you look, you see these muscle fibers are running this way, right? So you're going to expect that to be the lateral component of the fibers. Anything that runs perpendicular to it is going to be the transverse component. So the transverse component is binding the muscle fibers end to end, right? The lateral component is side by side. So the lateral component is always going to run perpendicular. So you see this is lateral, right? The lateral component is always going to run parallel. So you can see these parallel lines here. So what is the only component you're going to find, or excuse me, what is the component that's solely found on the lateral side? Those are going to be the gap junctions are found solely on the lateral side, right? That's what the question's asking. So the main thing is to remember when you're looking at this, that the transverse component is going to run perpendicular, and the lateral component is going to run parallel to it. So it's going to connect side by side. Okay, so I'll show you all the slide right here. So again, lateral component, the ones that are running parallel are going to, those are where those gap junctions are going to be, so they can talk to the cells on the sides, right? The transverse component, you could find the macular adherents and the fascicular adherents too. Okay, but remember the macular adherents, the desmosomal components are going to be found transverse and lateral. Okay, so they could ask you that too. Macular adherents is another name for desmosome, so you could see them both ways, which I believe y'all did that in FTM1 when y'all looked at the different cellular components, or the binding junctions between the cells. So just find the parallel side and you'll know that that's the lateral side. The ones beneath it that run perpendicular, the transverse side. Which of the following areas responsible for autonomic nervous system? So the autonomic system is a very primitive system. All your primitive functions such as respiration, your arousal tends to be in the brainstem. So that's where you're going to find that. And autonomics is another huge topic in medicine. So y'all will get that in a lot more detail. All right, so staying for elastic connective tissue. I just remember these are always those guys' names that they use for that. So silver stain is not going to be one of those that you use for that. Silver stain is for, what's it for? Reticular fibers, is that right? Somebody, is that right? Yeah, okay, cool. Yeah, and so remember, when you see these elastic fibers, you could see here, and usually it used to be called, they used to just call it elastic stain, but now I guess these dudes want credit, so they get their names mentioned. All right, what are we looking at here? Image below. This is a multilocular fat cell, right? So unilocular versus multilocular, they talk about this signet ring. You can kind of see the nuclei kind of pushed to the side. But remember, if you're looking at this is an H&E slide, the fat washes out, so you won't see any staining on the fat, right? So again, they're kind of throwing a lot of different factors at you that it doesn't seem to line up, right? Y'all are learning all kind of different stuff, but they're just like it is foundations to medicine. They're trying to just lay a foundation before they really get into clinical medicine. So this multilocular, you see this in infants, it's brown fat, right? It has a way, it's thermogenic, so it's a way of producing heat. This is what bears use when they hibernate, this brown fat. It's just a way, you're not really making storage ATP, you're just burning it off as heat. All right. When we talk about collagen and elastin, right? Lysine is what we're going to use for these cross-linkings. Okay, and you can see here. So remember, prolyl hydroxylase and lysyl hydroxylase are going to be what you use for collagen. When you, and you use vitamin C with that as well, right, as a cofactor. When we're talking about elastin, you use lysyl oxidase, right? Not the hydroxyl, the oxidase, and you use copper as a cofactor. So these are easy, straightforward questions. If you just, these are the kind of things, these buzzwords that they're looking for. All right. Gum bleeding and swelling, diagnosed with scurvy. What's the problem, right? Vitamin C, right? What is vitamin C used for collagen synthesis? This actually happened to pirates, right? They didn't have any vitamin C. They got scurvy, right? Yeah, there he is. All right. Yeah, straightforward, gum bleeding, problem with collagen formation. All right, triple helix. You've learned about this. This triple helix of glycine, proline, and hydroxyproline backed up, right? All right, now this is more of these vignette style questions you're gonna get. Oops, all right. Sudden change in vision, lens subluxation, buzzword, tall and thin for his age. There's family history. So there's genetic, aortic aneurysm. It's all in here, right? Long, slender finger. Okay, so what's the guy got? Marfan syndrome, right? I don't know if y'all know this story about the guy from Baylor. He was like 7 feet tall. He was drafted into the NBA. Like you look at the guy and you'd be like, the guy has Marfan syndrome. They never diagnosed him. So he was about to make a multi-million-dollar contract. And the NBA doctors, physicians said, nope, you can't play in the NBA because you actually have Marfan's and you're at risk for aortic aneurysm. So the 7 feet tall dude that was never told, even though he had some lens subluxation, no, he was never diagnosed, and he missed out on a multi-million-dollar contract. So yeah, that happened a few years back. He played for Baylor. So aortic aneurysm. So again, the point being is that these people with Marfan syndrome, even though they make great tall basketball players, they're not supposed to be playing sports. Okay, aortic aneurysm, and that's again because of the fibrillin, which is part of that complex, right? And you can see that here. This elastic fiber complex. Remember those big arteries, like the aorta, has thick elastic fibers, right? So if they're overused or like playing sports, they tend to split, the tunica medial split, and you can get aortic aneurysms, and so you're at risk for dying, right? So they like this one just because it tests a bunch of different modalities of medicine as you go forward. All right, everybody's favorite. Pharmacology. I like first aid for this stuff. I think they tell you what's important to know. So there's a pharmacology chapter in there that just has a lot of good tables. All right, so what are we asking about? Efficacy. So whenever you think about efficacy, decreased potency does not affect efficacy. So potency is always x-axis, okay? We're dealing with Km, so always keep those together. X-axis is Km, and that's your potency. Y-axis is efficacy. We want that to stay the same for this question. And that's going to be your Vmax. Oops, max. There you go. All right. So which one of these changes the x-axis, but doesn't change the y? So curve B, decreased potency compared to what curve A, right? Okay. So what we're saying here is we want to change the x-axis. So what you need to remember is Km is inversely proportional to potency, which means the lower the Km, the lower the the lower the Km, the higher the potency. So you could take a lower dosage of the drug and it would work more effectively. So we're changing the Km here. So by increasing Km, it's inversely proportional, we're decreasing the potency. So B has a decreased potency than A. But did we change the efficacy? Did we change this y-axis? No. All right. Lindsey and I had a question like this on our last exam, like it will never go away. So figure this out now and you'll be good to go. All right, how does C fit in? How is C compared to A?
Low potency and
Potency,
low
right?
efficacy.
Potency and efficacy, right? So we changed our potency and we changed our efficacy. Yeah. All right. But one of the tricks to definitely remember is that Km is inversely proportional. So the lower the Km, the higher the potency. Just think about it as drug dosage. If you can get the same effect from 1 milligram of a medication that you can from 10, right? The one with 1 milligram has a higher potency. Okay. That's what we're looking at here. So yeah, drug C has a lower potency and lower efficacy. Down and dirty, that's all you need. Now, what is D? Here's a trick because if you would think of an antagonist, a lot of times you say, well, you're going to get like an inverse proportion of what's going on. But all an antagonist is it antagonizes the positive effects, right? It doesn't actually do anything in reverse. Like if you have hypertension, well, let's see. Let's say you have tachycardia, right? And you take a medication, you take a medication, or there's a medication you could take to slow down your heart rate, but then you block that. I don't know if this is going to make sense. That doesn't mean your heart rate's going to go up, right? You're just blocking the effect of the decreased heart rate. Did that make sense? Okay. The point being is that the only thing an antagonist is going to do is prevent this. So let's say this increases your heart rate. Okay. So any of these medications increase your heart rate, but you take D with it, right? That doesn't mean that D is going to cause your heart rate to go down, right? It's just going to say, we're not increasing our heart rate. There is a difference. And I think I have a slide coming up because the opposite is an inverse agonist. So whereas these medications may increase your heart rate, an antagonist will keep your heart rate the same, an inverse agonist will decrease your heart rate, right? So don't get these confused. An antagonist is always going to lie flat on the line, just antagonizing the positive effects. All right, try this one. All right, so another term you can use, affinity, relates to potency as well. So you can add that. The more you can, the better you're able to bind to it, or the better affinity you have for it, the more potent it's going to be. So you can add that to your list of synonyms in a sense, right? So if A has a higher affinity for it, then the Km is going to be lower. So again, hammering home the point here that a lower Km equals an increase in potency, which now we know also means an increase in affinity, right? Same thing. Higher affinity, higher potency. But remember, that means it's a low Km, inversely proportional, low Km, high potency. All right, cool. There you go. All right. And I promise you, Lindsay, and my questions are chosen for a reason, okay? So conceptually, there's a reason, like these are considered very high yield. Board exam style questions, SGU style questions. These are the kind of things they're gonna ask you guys. All right, so some more terminology. How does an irreversible antagonist act? Well, you can see C being an irreversible antagonist works very similarly to the efficacy graph, right? To that, because we're affecting the y-axis. We're decreasing the efficacy. By irreversibly antagonizing this, we're changing our efficacy, okay? And that's what I have here. It works very similar to a non-competitive reversible inhibitor, okay? I think, yeah, this is from first aid. It's a little busy. Do I have more? No, okay, we should go through this. Right, so if we look here, what are we changing between these two graphs, okay? We're changing our x-axis. So this light blue line has a lower Km, so higher potency than the purple line. We didn't change our efficacy. Here, they're starting at the same point on the x-axis, so they have the same Km, but we changed our y-axis. So so we changed our efficacy, so this correlates to a non-competitive antagonist, okay? Now, why would you consider this one that changes the Km a competitive antagonist? Because remember, with a competitive antagonist, you can overcome the antagonism by adding more substrate. I think Dr. Trotz might have taught y'all this, right? Because they're competing for the same binding site. So if you continually add substrate, there's more substrate available to bind than the antagonist, okay? Now, it's different when you look at this because this non-competitive antagonist has its own binding site. So it doesn't matter how much substrate you add, this non-competitive antagonist will just bind to a different site, right? It's got a different parking spot, so I don't have to compete for it, right? So it's gonna change your efficacy, right? What kind of effect you're gonna get. And then here, if we do a partial agonist alone, you can see you don't get the full effect, partial agonist, all right? So a lot of this is just putting the nomenclature together, like low Km correlates to potency, potency correlates to a competitive inhibitor, whereas efficacy correlates to the y-axis, which correlates to a non-competitive inhibitor, okay? I don't know that I have a question, so I just want to point this out too. If you ever look at the Lineweaver-Burk plot, which is just the log of this, right? There's a trick. Let's see, how does this work? Yeah, so if, yeah, like that. So if I said, should have been different colors. This is an important point, just bear with me here. If I said blue was our baseline, like this, and then okay. So if you do a log of this, okay, if we said blue was our baseline and we wanted to know which line, purple line, is a competitive or non-competitive, and blue is a competitive or non-competitive. Y'all did do this, right? Or did y'all not do this yet? Y'all did this, okay. All right, all right. So the trick is if they compete on the y-axis, as in they cross on the y-axis, that's the competitive inhibitor because they're competing across the y-axis. It's just a trick, right? So if we say blue is our standard, green, because they cross at this y-axis point, is going to be our competitive inhibitor, right? I did blue over here. We said blue was our baseline. So what was, right, so So if blue was our standard and we said, what is green? Green is going to be the competitive inhibitor because they compete across the y-axis. And the purple is going to be non-competitive, okay? That's just, if you do the logs out, that's how it works. But the trick everybody uses is if they compete across the y-axis, that is going to correlate to your competitive inhibitor. All right, let's do this one. So this is that table that they gave you with the 90, 99, 99.9 thing, right? Y'all are familiar with that? Yes. Okay. If y'all have not covered something, y'all just stop me and tell me and we'll just move on. But we're assuming that they're pretty much standardized throughout the terms, right? But every once in a while they change some stuff around. All right, so let's see here. Our pH and our pKa is 1 off, right? So we use the equation. I think I have it. Let's see. We're going to use this, and I'll go back to it in a second. Right. So pH minus pKa is what we're going to use. pH is 2.5, pK is 3.5, so 1. So let me go to the equation and I'll show you guys. Now, so we're at 1. So it aggravates me, or I don't like trying to figure out where the hydrogen is, if it's protonated or unprotonated. It just takes too much time, and on the exam, I don't really worry about it. So this is what I do. You would expect an acid to be absorbed in the stomach. Acids are going to be absorbed in an acidic environment. Bases are going to be absorbed in a basic environment. So they're going to tell you that what you're working with. You're working with an acid. You're working in the stomach. So you would expect it to be absorbed, right? So then if we talk about this graph, if you would expect it to be absorbed, would you expect it to be more on the 90 side or on the 1 side, right? You would expect it to be on the 90 side. Most of it's going to be absorbed. So I don't really worry about this. You could do this. Acids are, when they're uncharged, they're protonated, right? And bases are unprotonated, but it just aggravates me. It's an easy way to mix it up. So if they give you a base and you're in the duodenum, obviously it's going to be absorbed. If they give you an acid in the stomach, it's going to be on this side. So if you use it in that method, if it's 1 off, it's 1 9. If it's 2 off, it's 2 9. If it's 3 off, it's going to be 3 9s. Okay. So whatever works for you, that's just, it's easy for me to say it's an acid. We're in the stomach, so I'm in the 90 spectrum, right? And I say, what's the number? It's 2. I got to use 2 9s. All right. So, but if you want to break it down, I put it here too. The protonated form is a weak acid, right? So the point is, when the acid, so we're looking at it here, it's going to be like HA. So it's not charged when the hydrogen is attached to the acid, which means it's liposoluble, which means it's going to go through the membrane. That's what you want. All right. When if they're dissociated, the base is not going to be charged when they're not together, right? When the hydrogen's dissociated. So in the intestine, the base is going to be liposoluble, so it's going to cross. I just don't like thinking about all that. I just like to say it's an acid in the stomach, so I'm in the 9s, okay? But whatever works for you. All right, cool. All right, let's do some math. Gross. And I did pull out, no, this ain't that part. Yeah, I think I did pull out the slide from your lectures with the equations you need to know. Ideally, if we were on campus, like I would tell you the first thing to do on your whiteboard is just write out the equations. Just regurgitate them right before the test starts. But as long as you know them and know which one to use, you should be fine. We'll take a break in a little bit. Come here. What you been doing? You want to say hi? Obviously been playing. This is Phoebe. I don't know if y'all met her yet.
Come here.
One of our mascots.
Gunner came to say hi too.
Yeah. So Phoebe's coming down to the island with me next term. So if y'all are there, y'all get to y'all could come. She comes and studies what she did when we were there the first time on campus. So.
Oh, you took her to campus? Oh.
Yeah.
I wanted to
Under
take Charlie to campus, but I couldn't take him on the bus.
Yeah, under Belford, she would study outside with us.
Oh.
Yeah. Oh, there's the answer. All right. So, right. So typically in these equations, you're going to want to, you have to find the half-life, right? So the first thing is, how many half-lives has it been? Well, they tell you it's been 2 hours is the half-life. It's been 4 hours. Okay. So steady state is 4 half-lives. Whoops, I'm gonna have to do this out. I thought I wrote it. Let's see. All right. So if we know, well, where'd you go? All right. So at 1 half-life, we're going to use 50%, right? That's by definition what the half-life is. At 2 half-lives, we're going to use 75, right? And at 3 half-lives, we use 87.5 or whatnot. So what we're saying is, how many half-lives has it been? It's been 2 hours. So it's been 2 half-lives. So at 2 half-lives, or 75, at 2 half-lives, you're going to be at 75% of steady state, right? And is 6. Okay, so at 2 half-lives or 75%, you're at 6. So if 6 equals 75%, 6 times 0.75 equals 8. Okay, this is kind of a weird way of looking at this. Most of the questions are a little bit more straightforward, but I remember having trouble with this one. So I wanted to add this one for you guys. So the point being is that we know it's been 2 half-lives. They tell you at 2 half-lives, the value is 6. So if we can correlate this 6 to being 75%, then we know when we get to 4 half-lives, or 100% of this, where it's not really 100%, you know, we just assume that 4 half-lives is steady state. When we get to 4 half-lives, we'll be at 8. Just multiply. Yes.
I think you're supposed to divide 6 by 0.75.
Oh, 6 times? No? Am I?
Yes, because this is rule of 3.
Oh,
so
sorry.
6
Yeah,
times 6
I'm
times
sorry.
75 divided by 94 or 95.
Sorry about that. Yeah, it's 7.75 times x equals 6. Can I blame Phoebe for it? She's here bothering me, my dog. 0.75 times x equals 6, right? Because we want to know what x is, which is going to be our steady state. So x equals 6 over 0.75. Sorry, it's really hard to type stuff out with your trackpad. Right, so that should equal 8. Thank you for correcting me. All right, cool. So y'all know this better than me. That's awesome. Let's do this one. So this one will probably be more like how your exam questions will be, pretty straightforward. All right, so we are starting out with 400. And we set, right? So that would mean 1 half-life. We get down to 200. And first 120 minutes, right? So we can say definitively that 2 hours is our half-life. Why is that? Because we know we cut it down in half from 400 to 200 in 2 hours, correct? So how many half-lives is 6 hours? 3. So in 1 half-life, we went to 200. In 2 half-lives, we'll get to 100. And in 3 half-lives, we'll get to 50. Right, first order kinetics, y'all learned about this. That means it's a constant percentage of what you're getting rid of, right? That's the best way the easiest way I could explain it is that you're always getting rid of a certain percentage. When you talk about zero order kinetics, it's a certain amount. What's the mnemonic? 8 is the mnemonic they use. Aspirin, phenytoin, and ethanol are all zero order kinetics. That's why it's very easy to overdose on those, because you're not getting rid of a constant percentage. You're not getting rid of 30% of this massive amount. You're getting rid of a constant amount, okay? So whereas first order kinetics, which was what most drugs use, you're gonna get rid of a certain percentage. Regardless of how much you have in your system, you're getting rid of, say, 50% at a time. Zero order kinetics, you can only get rid of a certain, not a percentage, but a certain amount, right? So they say you can metabolize, a shot of whiskey an hour or whatever, or 1 glass of wine or 1 beer per hour. That's a constant amount, not a constant percentage. So keep that in mind. Right, and of course, as always, steady state is, it really comes out to like 93%, but they consider 4 half-lives steady state. So it works both ways, whether you are infusing, doing an infusion of a drug, trying to get to steady state, or if you are getting rid of a drug from steady state, it always takes 4 half-lives. And this is what I was saying. So first order kinetics, regardless of how much, right, you're gonna get rid of a constant percentage, whereas zero order kinetics is linear. You're gonna be getting rid of a constant amount, okay? All right. I think the worst thing about these problems is they give you too many values, right? They're going to give you everything and you're going to have to figure out what to use. So this one's pretty straightforward. You're trying to find the loading dose. You use the loading dose equation, okay? They give you these values. Is it IV? Yep, IV. So F correlates to bioavailability. IV medications, you have 100% bioavailability. So F equals 1. Whereas oral medications, you only are able to absorb and metabolize a certain percentage of it. For all the questions you're going to get, I'm fairly sure they're going to give you IV infusion. So your bioavailability or your denominator is going to be 1. So then you figure out VD and your target concentration. Target concentration is the same thing as concentration at steady state, right? So TC equals CSS, same thing. So you can do that and you get 100 milligrams if you plug in the numbers. Let me see. I think I do have, yeah, it's coming up. I have the slide with all the equations you need to know. Try this one. This one's a little more difficult. I'll give you a hint. try to use the equations to answer this. That's all you get. All right. So this may not be intuitive to you guys yet, but what factor are we going to be worried about if someone has chronic renal failure? You're going to be worried about the ability for them to clear the medication, right? Though maybe at least in the question, the liver's fine. You'll be able to metabolize the drug, but can you clear it out of your system? Can you eliminate it? Can you pee it out, right? So clearance is going to be the factor that we are worried about. So this person's clearance is going to be decreased. Now, if we know our equations, what equation uses clearance and what doesn't? So loading dose is all you're really dealing with is volume of distribution, right? Clearance isn't really involved, but the maintenance dose has clearance as one of the values in there. So this is just a way where practically it comes into play. If someone is not able to clear the drug because they're in renal failure, you're going to have to give them a lower maintenance dose because otherwise the drug or the metabolites of the drug is going to accumulate in their system. Okay, so I like that one. Now, 4 stars, know these equations backwards and forwards. Like I said, the loading dose equation, very similar to the maintenance dose. If you plug it in, dosing rate here. So loading dose is going to deal with volume of distribution. Maintenance dose deals with clearance because you plug this into dosing rate. But make sure you know these. You can use 0.7 here for this. Some of these are kind of close to each other. So loading dose and maintenance dose, volume of distribution and clearance are very similar. It's just small parameters that are different. But whatever you need to do, make sure you know these equations. What I was going to say earlier, I think the hardest ones we had was where you needed to use 2 equations, like to figure out the problem. So like you had to use this equation to figure out volume of distribution and then plug it into this equation, right? So they'll give you the half-life and the clearance. They won't give you volume of distribution, but you want to figure out the loading dose. Okay, so you'll have to use this equation, figure out volume of distribution, then plug it into this equation. We may have had like one like that, but for the most part, they were all pretty straightforward. Okay, so again, the hardest thing about these is that they're going to give you a lot of extra information. So which equations are you going to want to use? All right. Postganglionic sympathetic neuron. So sympathetic is what? Running away from a bear, right? You want your eyes to be dilated, your heart rate to go up, your blood flowing, right? Blood flowing to your periphery, to your muscles. These are going to be your sympathetic fibers, whereas parasympathetic is rest and digest. Your eyes are constricted. What does meiosis mean? Meiosis means pupil constriction. The way I remember this is meiosis is a smaller word than mydriasis. So mydriasis is pupil dilation, right? Bigger word. Meiosis is a smaller word, pupil constriction. So for this, if you know the mnemonic, point and shoot, everybody's favorite. Point has to do with penile erection. Shoot is sympathetic, is ejaculation. That's how people remember that. You'll never forget it. Things such as bradycardia, meiosis, GI wall contraction has to do with with motility or digestion. So use these tests to your advantage, right? So even if you didn't know this little mnemonic and you said, we're worried about things such as running away from a bear, right? Well, your heart rate's not going down. You want your eyes dilated, right? So they're not going to be small, and you're not worried about digesting anything when you're running from a bear. So those are out. So you can, you know, again, this is that art of taking these tests. Try to get it down to your as simple as possible. Whatever method you need or whatever information you could pull from your brain to answer these, go for it. All right. We'll get into the autonomic nervous system in a bit. Y'all have had Dr. Trotz, right? Y'all have seen her break slides. She's the best. All right. Let's take a 5-minute break, and then we'll go through the last little bit, and Lindsey's got some cumulative questions for you guys. So let's do 5 minutes. And we're hoping, we're trying to figure it out because Lindsey and I are both, I'm going the first week in July, I'll be down on the island, and Lindsey's coming a few weeks later. We're going to try to do these reviews, like, I don't know what we're going to do. We're going to probably do them live, but then like live stream them for people that end up staying online. We haven't figured it out yet, but we're going to work it out because we do want people to all, you know, get to meet in person, not just at the bar. Bar's good, but not just at the bar. But so we're gonna try to figure everything out, but you know, ideally we want to try to do things live, so not only can y'all meet us, but y'all can meet other people in your class, and the more people you're able to study with and bounce ideas off of, the better. All right.
Brady, I have a quick question just before we go on. A lot of students I know, especially like in our WhatsApp group, we've been really stressed about for how much detail they're going to ask us about especially like the nervous systems, like, you know, how I know our slides had like specific pathways and names of the special or specific nuclei. Do we need to like memorize those, or just like, you know, I know like the preganglionic and postganglionic where they come from, but like, I don't know if they're going to ask us about the specific nuclei or the names of the nuclei or the ganglia names.
No, they're just introducing y'all to that.
Yeah.
But we're going to talk about the autonomics in a little bit. But no, just knowing the basics is going to be good for now. Y'all are going to do neuro where y'all go into all the different nuclei and stuff. But for now, just understanding the basics, you should be good. But on that note, we can go ahead and start looking at it. So again, parasympathetics is your rest and digest. You're going to find those fibers craniosacral, right? So in the cranium and the sacrum. These preganglionic fibers, or the autonomic ganglia. A ganglia is, the definition of a ganglia is a cell body outside of the central nervous system. So these are cell bodies. So these parasympathetic fibers are going to use acetylcholine. Actually, all of the autonomic ganglia fibers are neurotransmitter is going to be acetylcholine. But for parasympathetic, the postganglionic, the terminal fiber, is going to use acetylcholine. And for the most part, sympathetics is going to, when you're running away from a bear, you're going to be using the catecholamines like norepinephrine, okay? Now, the important thing about the sympathetics is going to be thoracolumbar, right? So parasympathetics, brain and sacrum, your sympathetic chain runs thoracolumbar, okay? Two really important exceptions that are kind of weird. The sweat glands, technically you're going to sweat, right? When sympathetic, you want to cool yourself off. Those receptors are at the end are muscarinic receptors, which means they're technically they're muscarinic receptors. They're still sympathetic, but you would expect if they were sympathetic, them to be alpha and beta receptors, right? But they're actually muscarinic receptors. So that's weird, right? Because it's still sympathetic. It's an exception. The terminal receptor is muscarinic. So remember, we're going to go through that in a second. And then the other weird one is the adrenal medulla. So in the adrenal gland, you're going to release your catecholamines. In the adrenal medulla, you don't have a postganglionic fiber. The preganglionic acetylcholine just binds directly to the chromaffin cells in the adrenal medulla, and they release the catecholamines into the blood. So there is no postganglionic fiber, okay? This comes into play when you talk about some of the medications they use, but that's a problem for another day. And then of course, somatic fibers don't have an autonomic ganglia. They go directly to the terminal endpoint and use acetylcholine, okay? So just make note of those two exceptions and you should be good to go. But even though they're introducing y'all to a lot of the drugs, when you go back through the drugs in term 4, it's much more highly tested. So I don't want you to focus too much on the actual drugs, but more about the receptors and what the receptors do, because they intentionally don't test y'all too heavily on it, because you get into it when it's more complicated, the pathways in term 4. So it's more about understanding the concepts right now and getting those down. All right, so a good point here, sympathetic always has a short preganglionic and a long postganglionic. So however you need to remember that, whereas parasympathetic has long preganglionic and a short postganglionic, right? Sometimes this postganglionic fiber is all the way in the organ, okay? So remember that. This is just from first aid, just kind of showing you those terminal endpoints, that synapse, the cholinergic or acetylcholine. So a lot of these are synonyms: cholinergic, acetylcholine, parasympathetic, muscarinic. These are things you're going to use for this one parasympathetic pathway. And then for the sympathetic pathway, you have noradrenergic, norepinephrine, sympathetic, adrenergic, words like that, those alpha and beta receptors. Now, this is one of the most important slides in first aid for med school. So when we talk about our adrenergic, our sympathetic fibers, we're going to use alpha and beta receptors, okay? Those are those terminal points. When we talk about cholinergic or muscarinic or parasympathetic, we're using our muscarinic receptors. Now, the best way to remember this, everybody uses this, is kiss-kick, okay? Now, so the alpha-1 receptor uses the GQ pathway, that G protein complex, it uses GQ. Alpha-2 uses GI, which is inhibitory. The beta receptors use GS, right? So y'all are familiar now, and we'll look at it in a second. The GS pathway goes through CAMP, goes through protein kinase A, whereas the GQ pathway goes through IP3 and DAG and goes to end up making calcium. I have a slide on it coming up. But anyway, so they can ask you something like, what receptor increases heart rate? And you know that, or what is the G protein coupler, or what is the G protein class, I should say. So increased heart rate, beta 1, you know it's KISS, right? So the S, GS, okay? So this is gonna come in handy a lot. This is a good trick. 1 heart, 2 lungs. 1 heart uses beta 1 receptors, 2 lungs, such as albuterol, right? Those beta 2 agonists. So that's how I remember these. And if we go back real quick, you can see heart, right? Beta 1s, stuff like bronchodilation, beta 2s, okay? Now, one of the tricks is at baseline, you're primarily going to be vasodilated. So beta 2 receptors are active, but when you actually start running from a bear, you get increased catecholamines. So you're going to get an alpha 1 effect, and that's going to cause transient vasoconstriction. So just think at baseline, all of us right now basically are vasodilated, beta 2s are active. If you get a heightened response, you go into vasoconstriction. So just keep these two separate. All right, so we look at some of the drugs. Again, you're trying to get the concepts down now. Primarily, what are the first line medications for a few of these diseases that we're talking about? That's what you're going to want to focus on. So we have direct acting and indirect acting. These indirect acting fibers work on acetylcholinesterase, okay? Acetylcholinesterase breaks down acetylcholine. So if you can affect the enzyme that breaks acetylcholine down, there's more acetylcholine available, right? So you can get a higher response. And then we also have these cholinergic antagonists, right? You really don't need to get into these too much, just kind of the basic ones. Atropine is really your first line for any sort of cholinergic overdose, at least a direct cholinergic overdose. Then we have the adrenergic drugs here too, okay? So y'all are just touching on this. Y'all are gonna get into, I remember stressing about this, all these medications, and then we had like 2 or 3 questions with medications on it. So that doesn't mean it's going to be the same for you guys, but I kind of feel like they do it intentionally because in term 4, you really get into it big time. All right, here's another trick I like to use. For the beta blockers, anything that falls from A to M is selective. So like atenolol, metoprolol, they all have a lol at the end, okay? Anything that is N through Z is going to be non-selective. That means the beta 1 response is equal to the beta 2 response. So it's things such as propranolol, okay? So you can keep these straight in your head going forward. All right, atropine. So first question, what is atropine? What kind of blocker? Even if you didn't know, what would, well, yeah, that's fine actually. Dry mouth, atropine is a muscarinic blocker, right? So you think salivation has to do with parasympathetics, digestion, right? So if you block that process of salivation, you're blocking parasympathetics. Therefore, you're blocking muscarinics, right? So atropine is a muscarinic blocker. Okay, cool. And you could see that here too, atropine, again, prototypic muscarinic antagonist that they use. They use it when people show up to the hospital in cardiac arrest. They give it along with atropine to try to start the heart up again. All right, try this one. So this is one of these things, we joke about this a lot. It's like you start reading it and you diagnose the patient and then they tell you the diagnosis and you get mad because you knew it already. And you're just like, you didn't have to tell me, but that happens, right? So,
Or
anyway.
they explain it and you're like, okay, I know the diagnosis, so I can answer this question. And then they diagnose it and it's like, wait, that's not what you wanted me to know.
Yeah, so yeah, so myasthenia gravis, what is the problem? You have antibodies against the postsynaptic receptor, right? The acetylcholine. So what's the goal here? So let's talk about how these patients present. One of the tests they use in the office is they tell the patient to like do bicep curls, just keep moving their arm like this. And over time, they get tired, right? And what's happening is a lot of the antibodies on the postsynaptic receptor are bound, a lot of the receptors are bound by antibodies, okay? So you only have a few available. So over time, they get weak. So these patients complain about fatigue throughout the day. Their eyes start to droop throughout the day. So what is your goal here? Well, what if we could increase the amount of acetylcholine in the cleft, right? So any of those receptors that are available will try to bind. If we increase the amount of acetylcholine, maybe we'll be able to bind them a little bit better. So how do we do that? Well, we block the enzyme that breaks down acetylcholine, right? So we can't really affect the antibodies that are bound to those postsynaptic receptors, but at least we could increase the amount of acetylcholine, right, to try to bind it more. Okay. That's my dog snoring if she's obviously over it, so don't mind her. All right, so same principle here. This is what we're talking about, this myasthenia gravis. So what is the goal when we use an acetylcholinesterase inhibitor? Well, we're increasing the amount of acetylcholine available to bind, right? So there's a few receptors available. If we increase the neurotransmitter, hopefully we could bind them. It's not an ideal situation for these patients, but it does help a little bit. All right, and you can see there, this is called ptosis, right? Usually it's bilateral in myasthenia gravis, and it just means, you know, the acetylcholine, all the receptors are bound. Again, a lot of the autoantibodies, and it causes ptosis. They can't really keep their eye open. All right, so these are the kind of things you're going to need to know in regards to the drug. So what do you use to diagnose this? Edrophonium. It's kind of interesting, right? So these patients show up, the doctor suspects myasthenia gravis. They give them edrophonium and like, right, they feel weak and they get edrophonium and they feel great. And they're like, oh my God, you cured me. But edrophonium only works for like a minute, right? So they're like, I feel great. And then they're like, oh God. And it's like, so that's how they do the diagnosis. But unfortunately, it has a very, very low half-life, short half-life. Okay, so you can't really use it long-term. Treatment-wise, you use the stigmines, neostigmine and pyridostigmine, okay? Yeah, we'll get to the other one in a second. All right, try this one. All right, so he's not a farmer for no reason. They always talk about farmers in this situation. Why? Because they use insecticides, okay? These insecticides are acetylcholinesterase inhibitors, irreversible, right? So it's kind of like when you treat myasthenia gravis. If you decrease the enzyme that's going to break down acetylcholine, you're going to increase acetylcholine, right? So if you block acetylcholinesterase and you increase acetylcholine, you're going to expect parasympathetic responses. If you look at first aid, they use dumbbells. Those are the symptoms, and you can see all of them there. But this is classic. If you ever see a farmer, you should know what they're talking about. Pupils are constricted. What is that? Meiosis, right? Okay, muscle weakness. So then they're asking what receptor mediates constriction of the pupils. So first question, are we dealing with the alpha or beta receptors or the muscarinic receptors? Parasympathetic, right? So we're dealing with muscarinic. So then if you look at the chart in first aid, what receptor deals with that? And that's going to be your M3 receptor. Okay, I have the chart coming up again. But what if I asked you, what is the G protein you use here? Remember the mnemonic? KISS, kick. So M1, M2, M3, it's a Q, kick, QIQ. Okay, so they could even ask you that. And thought I had the slide coming up. Never mind, let me go back to it then. Right, so look, M3, pupillary sphincter muscle contraction, meiosis. There you go, you know it's M3. There's the mnemonic kick, right? So you're good to go. All right. Again, these are, like I said, they use the mnemonic dumbbells in first aid, but these are parasympathetic responses, right? Actually, okay, wait, let's talk about this because this technically, why do we get sweating? These are all parasympathetic responses, right? Right, rest and digest, salivation, abdominal pain, able to void. Does anybody know why we get sweating? That's a sympathetic response, right? This is one of the tricks we use, or not tricks, but one of the things we had to recognize, because even though sweating is a sympathetic fiber, that terminal endpoint is muscarinic, okay? That receptor is muscarinic, which means it's going to bind acetylcholine. So the increased acetylcholine doesn't care. It's going to bind any receptor that'll bind to it. So that's one of the interesting things here. You're going to get these parasympathetic responses, but because sweating has to do with muscarinic, the muscarinic receptor, acetylcholine is going to bind it. Okay. All right. And this is what we're talking about, these organophosphates, acetylcholinesterase inhibitor, right? So you get these muscarinic symptoms along with sweating. Treatment for this, what do we give? Gonna give atropine for this. I know sometimes they say physostigmine. I doubt they put them both on the exam. For all intents and purposes, I would always go with atropine in this case. Okay, muscarinic antagonist. All right, cholinergic stimulation. What is this? Cholinergic, acetylcholine. So we're muscarinic, we're parasympathetic, rest and digest pathway. So we know that has to do with pupillary constriction. What is the opposite? Sympathetic, adrenergic, pupil dilation. You want your eyes nice and big when you're running from a bear. So this is rest and digest, meiosis, cholinergic, muscarinic. When you do these, try to say everything because they could use them interchangeably on the exam. All right, pilocarpine, it's a partial agonist. Y'all will get into this a lot more later. All right, try this one. Oh, this is a tough one. I found this in some book. I don't know. Oh, actually, it was in your notes, but so yeah, so actually what you see is that these muscarinic receptors are actually found on the vascular endothelial cells. Again, y'all do get into this a lot more, but I could just show you, it does show up here, but I think that's probably a low yield for right now. Before Lindsey and I did this term, I'd say maybe you need to know it, but being the fact that they really get into this a lot more and explain it in term 4, I would say don't get too stressed about that. All right, so what's going on here? Nasal decongestion. So like pseudoephedrine, right? Ephedrine falls into the adrenergic pathway, right? So what you would actually see is the GQ receptor activates phospholipase C. How do you know it's GQ? Well, alpha-1, this is an alpha-1 response. It says it right here. Remember our little mnemonic? KISS, right? QISS. So alpha-1 is Q. That's Q. GQ goes through phospholipase C, increases calcium. Alpha-1, Q. So I'm hammering this home for a reason because this really comes in handy, knowing this. And star this slide too. You're always going to, this comes up again and again. So you can see this GQ pathway, phospholipase C, splits into DAG and IP3, increase protein kinase C, and calcium. So when you think of GQ, think of that C, right? Phospholipase C, protein kinase C, calcium. When you go through GS and GI are basically the same pathway. S is stimulatory, I is inhibitory. You use A's, right? ATP to CAMP, protein kinase A through that pathway. So they could ask you any part of this, and they will. So just make sure you know that. All right, so what do you give a person with asthma? What's going to cause, well, so what happens in asthma is you give albuterol, right? So you get bronchoconstriction. Typically it's atopy or some sort of allergic reaction, right? So you get bronchoconstriction. So what do you want to do? You want to bronchodilate, all right? So what do you give? I'm sorry, so what you give is albuterol, okay? That's gonna be a beta-2 agonist. We know beta-2 is 1 heart, 2 lungs, so beta-2 is for the lungs. You give albuterol because that's gonna cause bronchodilation. So if you give someone a beta agonist for it, you definitely don't wanna give them a beta antagonist, right? Ever, right? That's contraindicated in people that have asthma, because albuterol is going to help the situation, a beta-2 agonist. But if you give them a beta blocker or a beta-2 antagonist, you can make the symptoms a lot worse. Okay. Constriction, right? Give you one for treatment. Don't give the antagonist to that ever. That's a good rule of thumb. All right. Diagnoser, somebody. Yeah, exactly. I don't know if y'all have seen the memes. It's so funny. Like the guy has like he gets like hypoglycemic and passes out on a plane. And like a med student's on the plane and he's like, he's got pheochromocytoma.
It's a video.
Oh, yeah,
Yeah.
right.
And he goes through this whole thing. It's like, is it this? Is it this? Is it this? Is it this? And then he goes, pheochromocytoma.
Yeah, he's like, obviously the guy's like hypoglycemic, like he needs like some crackers or something. Yeah, can you find it, Lindsey?
Hold on, let me see.
It's that guy's TikTok. I don't have it,
Yeah,
but you
it's
have it, right? Yeah.
hilarious.
It's just funny because med students are like they're like, give him a cracker. The med student's like, no, he's NPO. He can't have oral medication in case we need to do surgery. It's very funny. Okay, sorry. All right, so yeah, pheochromocytoma. The thing you want to look for is those. So pheochromocytoma is a tumor of the chromaffin cells in the adrenal medulla. It's going to increase your catecholamines. VMA is a byproduct found in the urine that you have from the catecholamine breakdown. Okay, so any sort of increase there will cause increased catecholamines. So first line treatment for that is phenoxybenzamine. That's what you give. All right, and this is from First Aid. You could see this treatment here there. Lindsey posted it. We're gonna have to take another break and so everybody can watch it. Yeah, right. So that's a good point, right? So you'd never want to give a beta blocker before you give phenoxybenzamine. Think about that. If you gave a beta blocker and this person is having uncontrolled catecholamine release, nobody's listening. They're watching the video right now. Okay, it's fine. Y'all watch it later. Y'all pay attention, kids. If you give a beta,
learn about this in term 1 that you don't give a
well, think about it. If you give a beta blocker first, you're going to get unopposed alpha 1. You're going to get very much
I don't remember
vasoconstriction.
learning that until this term.
I still didn't learn it. So listen, we're going to figure it out together. All right. So you're going to give it phenoxybenzamine first. That's the whole goal here. Phenoxy for pheochromocytoma. All right.
So why not phentolamine?
I think you can. Okay, yeah, I think you can, but first aid says phenoxybenzamine. Phenoxybenzamine, I think first line treatment is give phenoxybenzamine plus a beta blocker, because phenoxybenzamine doesn't technically work on the vasculature. But I think you can give ventolamine. I don't think they put both of them as an answer choice on the exam. Yeah, oh, thank you, Kishore. Phenoxybenzamine has a longer half-life. That must be why they use it first. Yeah. Ventolamine for surgery, that makes sense. Okay, cool. All right, and you can see that here. And these are from your notes, so, but I don't think they would give you both as an option.
Don't stress out too much about this farm. Brady already said that at the very beginning. Learn what you need to know for the exam, but then just know that they're gonna kind of drop a whole ton of stuff on you in term 4. So yeah.
Oh, phenoxybenzamine is irreversible. Yeah, that is true. Good point. And we were curious too, until term 4, we were like, we still didn't know why in FTM, like we were all worried about the drugs and they didn't test it. Well, we do think it's intentional because literally we did a whole module on where y'all have FTM, we have FTCM, Fundamentals of Clinical Medicine. So yeah.
Yeah, year 2, you go over the pathology of everything you did in year 1. So if you don't feel like you know stuff right now, there's a reason to the madness. And you don't actually understand the reason until you get into year 2 and you're like, oh, okay, I see why you did that. That makes total sense. And so just kind of accept it, accept the process, because there is a reason.
Just take it.
Yeah. Yeah, you really just got to take it. Then you get to year 2 and everything kind of falls into place.
Yeah.
You're like, okay, yeah,
They know
I get
what they're
it.
doing. All right, so what's this guy got? He is big guy, but he has female characteristics. So this is classic for Klinefelter syndrome, XXY, right? So what's the problem here? Because of that extra X, you actually have low testosterone levels. All right. Yes, and you can see Klinefelter here. So they tend to be tall guys with female characteristics, tend to be infertile, testicular atrophy that leads to the low testosterone level. All right. I have a silly trick to remember this. If it doesn't make sense for you guys, don't worry about it, but this helps me out trying to determine what falls in what. Oops, did I do it? Oh, okay. Well, I'll just tell it to you guys. So if you skip the first X, excuse me, if you skip the first X and you look at the second and third, if there's one of each, it tends to fall in meiosis 1. Okay, so there's one X and one Y. This tends to fall in meiosis 1. If you skip the first X and there's 2 of the same, like this here, it tends to fall in meiosis 2. Now, I don't remember any questions where they started asking about XYY or XXX. They really asked most of the questions about Klinefelters, right? So Klinefelters tends to fall in tends to be XXY. Now, tell me this, for this one right here, did the problem happen in mom's pathway or dad's pathway? Dad's, right? It has to be. How do you get 2 Ys in the gamete or in the fertilized egg? You'd have to get it from dad. So in other circumstances, it's hard to tell because sometimes you can get 1X. Well, we could do this one. How about this one over here? Where did the problem happen? XXY.
Dad?
Well, you got the Y from dad, right? So you had to get these 2 X's from mom, okay? So this is a case where the problem would happen in mom's pathway because you got the Y from dad, that was okay, but you got both X's from mom. Now for this situation, it's hard to tell because you could have gotten the 2 X's from mom or 2 from dad. A little bit more than you need to worry about, but the point being, the trick I like to use if there's, skip the first one, if there's 1 of each, it tends to happen in meiosis 1. All right, we could go through this, but for the sake of time, I'll just do it quickly. If the problem happens in meiosis 1, you see that both sets, well, let's do this first. The N correlates to the chromosome type, right? So you have two types here, right? So after the initial replication, you get two types that correlates to the N. The C here, or it's usually the D, correlates to how many sister chromatids you have. So when you talk about haplotype and how many sister chromatids you have, that's how you do it. So the N correlates to the copies, and the D correlates, the DNA content correlates to the number of sister chromatids. So now, after we've replicated, if there's a problem in meiosis 1, they didn't split properly in the first technical split, right? If the problem happened in meiosis 2, you see meiosis 1 happened properly. Meiosis 2 is where they had the problem. So that's where you can get the trisomies. Now there is this concept of trisomy rescue. Sometimes the cells, when the cell recognizes that there's 3 chromatids in there, it can kick one out, but it's a random type thing. So this is why sometimes y'all talked about Prader-Willi, and though y'all did do that, right? Yeah, that was, yes, Prader-Willi, yes, okay, good.
Yes.
Yeah, so so that's how you can get those uniparental disomies with Prader-Willi, just because sometimes in trisomy rescue, they kick one out and they accidentally kick the 1 of dads and leave the 2 of moms, or vice versa. Anyway, so that's just a little trick I use for that. All right, let's try this one. So give me a diagnosis.
Is it the tau 13?
So it's one of, so remember, Patau is 13, Edwards is 18, right? So they're very similar. I have a slide coming up to tell the difference. Honestly, I still have to look it up. I don't really remember them, but the abnormal feet are the rocker bottom feet, and the clenched fist. That's what tends to be with Edwards. So there is an easy trick to remember these. But this is how it breaks down. Remember the CAG repeats, those are those trinucleotide repeats. Those are found in Huntington's disease, Fragile X syndromes there. So Patau is you hit P, puberty, around age 13. Edwards, E, you can vote, or elections are around 18, and D, drinking age is 21. So that's how we remember that. So, and it says it here, election age, puberty, or something, drinking age. But these are the differences. Yeah, this hand clenching tends to be Edwards, and then Patau tends to have the cleft lip, cleft palate, sometimes holoprosencephaly, meaning they don't have a split between the hemispheres in the brain. Okay, so keep these separate, and but they could ask you those. That little trick's a good way of knowing it. And then these are some of the lab values. I don't know if y'all really got into this yet, but some of these are important, specifically in Down syndrome. You'll get elevated levels of beta HCG and decreased levels of alpha beta protein. Maybe too much. I don't know if y'all did these.
We didn't get into that yet.
All right, yeah, then let's not worry about that one then. All right, now, this is another turn forward thing. Lindsey and I just had our test on all of the chemotherapy regimens and everything, and it was not fun. But what you actually have in some of these cancers is this translocation. So what happens is you have some sort of oncogene, or something that's gonna constantly want to transcribe, and it's matched up, it's translocated on a different gene. So this translocation happens from chromosome 9 to chromosome 22. So BCR is going to be attached to this ABLed, and it's going to be a transiently active tyrosine kinase. What does that mean? Well, it's just going to keep replicating, right? It's going to keep replicating, and you end up getting leukemia. So you get increased red blood cells or increased myeloid progenitors. Okay, so, and then, but this is just introductory for you guys, but this other reciprocal translocation is between chromosome 8 and chromosome 14. That could lead to Burkitt's lymphoma. You know that Myc is now an oncogene, right? So if you put this oncogene next to another gene, you're basically telling the gene, the oncogene's telling the gene it's next to, that you get to do whatever you want. You get to keep transcribing, right? So this is a dangerous situation, particularly in these leukemias and lymphomas. Now, Robertsonian translocation has to do remember some of these, it's like a little nub. I don't know what better way to say it. It's like some of these chromosomes just have like, they have a long arm and then they have this little nub on the side. And so these are 13, 14, 15, 21, and 22. So if you have a translocation and the two long arms of these chromosomes connect, then the two little nubs connect. And when those nubs connect, they tend to be lost, right? So this is Robertsonian. Whenever you talk about Robertsonian translocation, you're talking about this little baby P arm. All right. Diagnosis first. Yeah, right. Very good. So this is DiGeorge syndrome, okay? They use the mnemonic catch-22. I may have a slide on it coming up, but you see this deletion on chromosome 22. The catch is for, right, the catch is for the symptoms, right? So one of them, the H is for hypocalcemia, okay? So they get thyroid hypoplasia. They don't have a thyroid gland. And in attachment with that is the PTH that has to do with calcium. So if you don't secrete PTH, you can't bring calcium from the bone back to the blood, or from anywhere, basically, for right now, just from anywhere into the blood. So you tend to get hypocalcemia. And you see that here, this DiGeorge syndrome, or this 22q11 deletion. And this is the symptoms. Again, yeah, here we go. Catch-22, so cardiac abnormal facies or facial features, thymic aplasia, and that's gonna lead to the hypocalcemia, but they also get cleft lip and cleft palate. Right, so. All right. Diagnosis. This is a little tough, I didn't really give you. What if I said he had self-mutilating behavior? Yeah, exactly, right? Lesch-9 syndrome. So that one of the characteristics of this is they say self-mutilating behavior. They'll bite their lip, they'll bite the tips of their fingers. Interesting how that, I don't know if they even know how that actually comes about, but it's pretty interesting. Yeah, I know you got to just say all these words out loud and you get a little bit better at pronouncing them. I still mess them up all the time, so don't stress that. So this pathway has to do with PRPP, right? Okay, so PRPP, as you see here, metabolized by HGPRT. Now, obviously it's up to you, but like, I don't memorize hypoxanthine, blah, 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 blah. Like I just memorize HGPRT, and when I see it on the test, if it's written out, you can kind of work out what's HGPRT. So if that works for you, I just find it easier than trying to regurgitate these long words. All right, so ordic acid urea, there's two forms. The form we're worried about right now, there's another form in the urea pathway, but here we're worried about pyrimidines, okay? So this is what we're worried about, the T's and C's, and obviously the U's for RNA. So they're just brushing on this. Y'all will get into this a lot more later, but this is the concept of this pyrimidine pathway. This is a lot of nonsense, but you kind of got to know it. Not all the pathways, but the major pathways, right? This is where the ordic acid comes in. And then y'all will get into some of these chemotherapy regimens later on. But what's interesting is a lot of the chemo drugs work on this pathway, because if you don't have purines and pyrimidines, it's very difficult to make more cells, right? So if you can limit the amount of purines and pyrimidines, you can help to limit the tumor spread or the increased cell proliferation. HGPRT, so that You can also see stuff like gout, allopurinol, and uses xanthine oxidase will block that. That's in that same pathway, but I think the only disease we talk about specifically congenital is the Lesch-Nyhan syndrome. All right, so we're going to try to silence this gene. So you need to keep in mind, think about it like this. If you had a gene and you put a bunch of methyl groups on it, is it easy to transcribe, like these big bulky methyl groups all over the place? No, right? So if we're making it silence, we're making heterochromatin, right? Active is euchromatin. So we're trying to make heterochromatin. So methylating everything, you're kind of putting these bulky groups on it so it can't be just transcribed. Let's see if I have a slide. Shoot, okay. So what goes together is methylation and deacetylation, okay? Methylation and deacetylation is going to silence it. Demethylation and acetylation are going to make it active, okay? Now, how does so this is the methylation, you put these big groups on there, you can't transcribe it, but this is how the acetylation works. So if it's acetylated, it has a positive charge, the histone, right? And the DNA is negatively charged. So if the histone's acetylated, it can bind, and positive binds to the negative DNA. If you deacetylate it, you get rid of the positive charge. So the histone's not charged, it's not going to bind the DNA. So if it doesn't bind, the DNA is free to transcribe. So just keep in mind, I always think there's like always a D. So like methylation plus deacetylation equals not active, right? And then there's always a D. So D, well, shoot. Not gonna work. Hold on one second. Sorry, guys. Let's see. Demethylation plus acetylation, meaning it's that histone's positively charged, right? I don't know what's going on right now. Plus acetylation, which means it's positively charged, means it's going to be active. Okay. Don't forget that. That's going to come back again and again. All right. Multifactorial inheritance. So this is when we talk about Mendelian inheritance, right? There's a lot of factors going on, and this is classically what happens when we think of all really genetic components, right? These all have to do with like genes in an environment versus your family and the proband. So this kind of talks about this multifactorial inheritance, but you can look at genotypes and stuff like that, but a lot of times this comes down to multiple factors that have to do with this inheritance pattern. I think there was like a DLA on it, so it's not terribly important. All right. So the sooner you learn these nutrition lectures, the better. They tend to put them right before the test because they're not like super important and they're fairly easy to go through. But if you learn them now, you'll be good in the future. And Dr. Trotz loves the Mediterranean diet. So make sure you know that. So increased oleic acid, this 16 carbon compared to the Western diet. That's classic here. So oleic acid, point being you want less saturated fats in your diet, right? Saturated fats lead to increased cholesterol and atherosclerosis. All right, let's see. So why is she swollen? Why does this child have edema? Rice milk. This is called protuberant belly, is called ascites, right? So a lot of y'all are going to get into this a lot more detail later, but this is classic protein malnutrition. So these proteins hold the fluid in the vasculature. And if you don't have that, a lot of this fluid just kind of leaves the vessels and goes into the extracellular space. All right, so that's how you get ascites. This is commonly called Kwashiorkor's disease. Yeah, you can see this guy. So he has a protein malnutrition, and you see this protuberant belly. So a lot of like albumin holds a lot of the fluid in the vessels. So if you don't have these proteins, everything gets leaky, okay? And again, y'all are gonna get into this a lot more when y'all get to renal, but that's classic. If you see a malnourished child with ascites or protuberant belly, you're thinking of a protein malnutrition. Marasmus is a complete caloric malnutrition. It means everything, okay? So where does RB and P53 work? These are, again, very high yield stuff. They're cell cycle regulators. So P53 is a component of almost 50% of the cancers out there. So it's a cell cycle regulator. So it's a tumor suppressor gene. So if you're able to activate P53 or RB, you're able to stop the cell from transcribing, okay? It's literally gonna suppress it. It's gonna say stop at the G1S checkpoint, that G1 into synthesis. So before the cell starts synthesizing, P53 will stop it, right? So if there's a mutation in P53, you're not going to be able to stop the cell from transcribing, okay? So that's what's classically called a tumor suppressor gene, right? If it's mutated or not active, the cell can do whatever it wants, and that's by definition a tumor, right? And these are these tumor suppressor genes. You lose the function of them, the cell's going to do whatever it wants, right? Now, I don't want y'all to get too bogged down on this. Just maybe the ones that are bolded are probably the ones you want to have a correlation with. But again, this is definitely, it's very hard with FTM because they introduce you to things, but you do a lot of it later. So don't get too caught up on this. This is a good differential between this familial adenomatous polyposis and HNPCC, but it's two different mutation pathways that lead to not a similar presentation, but they both end up with polyps, okay? So the gatekeeper are the tumor suppressor versus the caretaker, the proto-onco, or the, I'm sorry, it's a DNA mismatch problem, or sorry, a DNA repair problem, and that's the caretaker, right? Because that the HNPCC has to do with DNA repair. And y'all could look at first aid for that too if y'all want any clarification. Diagnosis first.
Is it ZP or XP?
You got to say it out loud. What is it?
Xerisoma pigmentosum?
You close enough. Yeah, xeroderma pigmentosum. Yeah, very good. Yeah. So what's the problem here? Thymine dimers. So we all actually make these thymine dimers in UV light, in the sunlight, but we're able to repair them. These thymines on the same strand kind of bind, they dimerize, but we can fix them. But if you make these thymine dimers and you aren't able to repair them, that leads to xeroderma pigmentosum. Yeah, exactly. So it's a nucleotide excision repair. You cut those nucleotides out and you resynthesize them, okay? You can see that here. These kids have to really stay out of the sunlight. It can lead to different sorts of cancers. Yep, skin lesions, you can see that here. All right, and then there's also base excision repair, and that's where you literally just kind of clip out a little base and you can go back, where nucleotides have to do with a longer sequence. So I think as long as you have a general understanding of what these do and the whichever specific diseases they talked about in relation to them, you should be good to go. And you could see that here. Yeah, know the diseases that they talked about because it'll be pretty straightforward on the test. Diagnose the guy.
And muscular dystrophy?
Yeah,
Dystrophin?
dystrophin. Yep, that's right. So Yeah, Duchenne. Sorry, yeah, it is a mutation in dystrophin. It's Duchenne's muscular
Yes,
dystrophy,
Duchenne,
right?
yes.
Yeah, you're correct. So it's a problem with dystrophin. So there is a difference. There's Duchenne's muscular dystrophy and Becker's. Becker's is an in-frame deletion, so you do get some dystrophin. So these patients tend to do a little bit better. What's really sad about Duchenne's muscular dystrophy, they're usually wheelchair bound by 12, and they usually pass away by like 20. So their reproductive fitness, meaning are they able to have children, is pretty much zero, right? So when you see this mutation, it's really a de novo mutation. You're not seeing it pass along because these people with these guys, because it's X-linked recessive, they tend to not have children. So this is a de novo or a new mutation that forms. But yeah, this is a problem with dystrophin. And you can see these other ones that y'all talked about. I left these in gray. I wasn't positive y'all talked about them. So if not, don't worry about it. But y'all did talk about these other ones. All right, cystic fibrosis, another one of those things that comes up again and again with that chloride transporter. If it's messed up, chloride can't go, sodium can't go, so then water can't go. So if there's no water, you get mucus buildup, leads to infections, leads to infertility, leads to difficulty digesting stuff, okay? And you could see that here. What does CFTR show? It shows allelic heterogeneity, which is important because the most common place on the gene where you can get a mutation is this 508 place. But class, I'm sorry, she's snoring so loud. But you can have a mutation all along the gene, anywhere really, and it could lead to CFTR. So mutations on the same gene is allelic heterogeneity versus locus heterogeneity, which are mutations on different genes that cause a disease, okay? Now, allelic heterogeneity and compound heterozygote go together. Why is that? Because to have a compound heterozygote, you have to show allelic heterogeneity, okay? What is a compound heterozygote? That means on the CFTR gene, you had one mutation at a place from mom and a different mutation at a place from dad, okay? Now, since it's autosomal recessive, you inherited both mutations. Now, even though the mutations from mom and dad were from different places on the gene, you still have two messed up copies, right? So you're gonna get cystic fibrosis, and because you got them from different places, that classifies you as a compound heterozygote. So they will never put both of these as answer choices on the test, because for you to be a compound heterozygote, you have to show allelic heterogeneity. All right, so sickle cell. I live down in New Orleans. I've seen a lot of this. It's really sad. There's a high sickle cell population down here. These kids come in with these pain crises. Unfortunately, they're off of school trying, they have to get morphine and stuff like that just because, they're just trying to get by. And it's just a really sad thing, but there are some new medications coming out that are really helping these kids get by. So what actually happens, y'all are just getting into the genetics of it right now, but they tend to get hemolytic anemia. This leads to the jaundice of the eyes, or the scleral icterus, they cause it. But you're just basically talking about the genetics right now. So they like this terminology. So don't forget this. It is a mutation at the 6th position of beta globin gene. It changes glutamic acid to valine. Okay, it's the 6th position. Why do they want you to know that? I don't really know, but they do. So what ends up happening, you take a negatively charged glutamic acid and you're replacing it by a non-charged valine. So you end up making it hydrophobic, right? The glutamic acid, that negatively charged, keeps it hydrophilic in the water. But by just changing this 1 point mutation, you make this what's called a hydrophobic pocket, right? So the cells end up collapsing on themselves. They end up sickling, okay? And when these cells sickle, they end up bunching up in circulation, and it causes a lot of pain to the patient, okay? So you definitely want to remember that. 6th position, glutamic acid negatively charged to a neutral valine, okay? And then Duchenne's muscular dystrophy, this is what we're talking about. One of the common features they call pseudohypertrophy of the calf. They don't have that dystrophin musculature, that dystrophin muscular gene. So this is like fatty deposits in the calf. So it looks like they have large calves, but it's actually non-functional, right? They use what's called, if y'all can look this up, it's called the Gower maneuver. They really use their hands and their hips to stand up because their girdle muscles and their legs aren't very strong. So this will come up again and again as well. Duchenne's is X-linked, and there's the Gower sign. That's what they use. And we kind of talked about that. And then the difference between the, like I said, dystrophin is a frame shift mutation. So you get really a almost absent amount of dystrophin in that musculature. Whereas Becker's muscular dystrophy is in frame. So you get some dystrophin, but not all of it. All right. That's all I have for you guys. Do y'all want a little break before Lindsey does questions, a couple minutes? How's that sound?
Yes, please.
Yeah, no worries. Okay, we'll take a couple minute break. Yeah.
Brady, can I ask you a question in the meantime, if that's
Yeah,
cool?
sure.
Okay, I was just wondering what you think the bulk of our focus should be in the next 24 hours.
Ideally, I would try to do questions, like go back through the IMCQs, go back through the ESOF quizzes, just to kind of wrap your head around what the teachers feel are important, right? What were the questions that they were asking? Do I understand these concepts? But for Dr. Sobring, he likes, you know, these genetic questions are very clinically relevant. Well, just in general, everything clinically relevant is going to be your most high yield stuff. So take the diseases and work backwards from them. Say, this is cystic fibrosis. These are the symptoms. These are the genetic problems. So all of the questions, as you know now, are vignette style questions. They're going to say a blah, blah, blah year old patient comes in with blah, 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 right? So you want to focus on the clinically relevant stuff. Like Lindsey was saying, and I said, the drugs are really not, at least traditionally, haven't been tested as much. So you can focus more on just the receptors and stuff like that. The stuff we covered in the pharmacology, that's about as far as they're going to go. They'll give you all a couple of graphs, talk about KM, talk about Vmax, and you should be good there. But besides that, yeah, I think we really hit the high points for sure.
Okay, may I do one follow-up question, if you don't mind?
Of course,
yeah. So in regards to testing questions, if I've already like completed the Sakai's and IMCQs, would you ever in your life recommend UWorld or not so much?
Not term one.
Not right now.
Not term one.
No.
There, some of those question banks, you need a lot more information to be able to answer those questions effectively. That's what me and Brady were talking about, how a lot of the stuff in term one is in year one is expanded upon in year two. And until you get to that point, you can't answer those questions effectively. And so those questions are going to, the UWorld questions are going to expect you to know a lot more than you do right now.
Excellent, thank you.
Yeah, like it's most of it's pathology based. Like the way SGU set up is your first year, you have to know what normal is to know what abnormal is. So really that first year, you're trying to wrap your head around what, you know, the normal body's supposed to be doing. But once you get to second year and you start getting into the pathology, that's what's really more highly tested for sure. So don't stress out about that right now.
How about like identifying the tissue types, like the nervous tissue types? Is that high yield? Like being able to
what?
Like being able to recognize the cerebellum, the tissue from there, the molecular cells.
No, that's going to be term two thing. For the neuro stuff, the biggest thing you want to be able to do, and I have a question on this, you need to know the spinal cord really well. And so you need to know what pathways go which places with the spinal cord. That's the biggest thing.
Okay, thank you.
Okay, yes, I had a question. Yes, I am in IEA. I'm actually the IEA is the honor society. I'm actually the president next term. So we'll be down in fall. Thank you. Yeah. So yeah, I'm the IEA president. So the honor society runs a lot of tutoring. Once y'all finish term one, if you make above a 90, you get the dean's letter, you'll be able to join IEA, and then I get to be your boss. So that's awesome.
Stop saying boss.
The balls.
Brady and
Yeah.
I are going to try to, because I'm the SOM president for SGA. So Brady and I are going to try to do a lot of work in helping the transition back to the island, because SGA and IEA are kind of the most prolific organizations on
Yeah.
campus.
Yeah, we are.
Thank you, Kishore. But so IEA and SGA are really going to try to help ease that transition back to campus and everything, and then set, whoever our successors are up, in August or the next January.
And so technically, these reviews Lindsey and I do are not affiliated with the school, just because there's a lot of red tape to go through, and we like to do it on our own. I will post the review later tonight as soon as it compiles and everything, and I can upload it to YouTube. But we will do stuff. Lindsey runs stuff through SGA and IEA. We're going to do stuff on the island as well. If you're staying home, we won't leave you out. We're going to do things together. But like I mentioned earlier, Lindsey and I are going to continue to do these reviews for you guys as well.
How important is getting A's in med school? You need to get as high of a grade as you can. Now, note that your transcript is going to show your WMPG. That's your weighted cumulative something. And so it's 1 grade encompassing 4 years of medical school. So on your transcript, it's going to be the grade that you end it after year 4. And so you need to do as best as you can right now. If you don't get honors right now, don't stress about it. You have time to graduate with honors. But your ending score, which on your transcript is going to show honors, high pass, pass, or fail, that is important, especially in a school like ours, Caribbean medical school, and so many students attend. You do want to get a good grade.
How are you from Texas and you say Caribbean? The Caribbean?
I don't know. I don't know.
Did you have a question?
Am I supposed to say it a certain way, being from Texas? Caribbean?
I don't know. I'm just making fun of you. Did you have a question, Monique?
No, I don't know.
Hey guys, thank you again for such a phenomenal session.
No worries.
You guys are brilliant. I don't know how you guys do it. So in awe of the both of you, Lindsey and Brady. I want to ask, in terms of the cumulative material from FTM1,
I never study cumulative material.
No?
I never do. In year 1, you don't actually have that many cumulative questions on your exam. It's like 5 to 10 maybe, and they're very surface level. Okay. So they're not going to be to the extent you were tested in FTM1. And I never, ever, ever study the cumulative questions. If you want to study the cumulative questions, go back and do all of the quizzes, the ESOP quizzes.
Yeah, if that. And I honestly, I don't know anybody that does, because at the end of the day, it's much more important that you focus on the new stuff. And like Lindsey was saying, the cumulative stuff really is like, those are easy points. It's stuff that you would expect to get right. So I wouldn't spend any time going back through that. If anything, like Lindsey was saying, you could go back through the IMCQs if you have time.
Okay, awesome. Thank you so much.
No worries.
Yeah.
And after this is over, I'm going to update the link with Lindsey's questions too. So y'all will have those as well.
The genetic testing methods, there are definitely a good amount of questions.
Wait, that was cumulative, right?
Testing methods.
That was from the first
Oh, I don't know. I don't remember when that was.
We learned, we went over a lot of the genetic testing for like with the disease, for diagnosing the diseases, this block. But it was really just like karyotype.
Yeah, I would know them in correlation to the disease, but like actually going back to that old stuff, like the ASO blots and all that, like I probably wouldn't bother doing that. I still don't know it, so don't even like.
Yeah, I don't know it either. That is my weakest point from term 1, not gonna lie.
It's just the problem is that you can honestly use a lot of those multiple tests for the same thing. And it's just like, why? Oh, it's like, oh, now money is involved and you're like, oh, we do this because it's cheaper. It's like, we can't, like, I don't know what insurance you have. Like, so it's, yeah. So, but don't stress about stuff. Yeah, you don't need to worry about that.
Okay, do you guys want to get doing on some questions? I don't have very many. We did a lot during the review, but I do have some cumulative stuff and some of these big concepts. You okay, Brady?
Nope, my audio went out. You're good.
Okay. So let's get started on some. Why do I still have this up? Yeah, you guys are getting this. So to piggyback off of this, somebody asked me privately if we have to know the different defects, the gene defects, all of these things for each respective example. Yes, you do. It's easy points. It's really easy points if you just make a list of it and memorize it. You should be able to get them because there's no trick here. With this genetic stuff, there's no trick. It's do you know it or do you not? Sometimes you might have to be able to diagnose the patient from the presentation, and that gets a little trickier because you have to be able to distinguish between the patient presentations, but there's no trick with any of these. But I'm gonna go ahead and show you the, oh, not on this correct screen. I have two external monitors, and so I'm clicking different places. So it is double minutes. So breast carcinoma, double minutes is the example that they give with breast cancer here. So that is going to be the answer to the question. So again, if it shows you a defect example with respect to a particular pathology, you need to know it, and they will use that example on the exam. And just an example of what we were talking about earlier, like in term one, I don't think I understood like half of what this was talking about, but like reading this now after going through term four, I know what each of these things are talking about. So it builds on top of each other. So just trust the system. Yeah, DeGeorge is probably one of the more easier ones because I think they start talking about this almost week one or week two. And so they kind of get in your head very immediately. And so I'm really using this question as an example of you do need to know the different translocations and everything with respect to each disease. So this one, of course, is the 22q 11q deletion, but you need to know it for all of those deletions, translocations, because they will test this. And again, make sure that you can tell the different presentations. If they give you the presentations in your notes, make sure you do know the presentation so that you can diagnose the patient and be able to get it on the exam. So there's a split, and I was anticipating this split because you have to read the question very carefully to get this answer. I'll give you guys a few more seconds to get your answers in and think about it. Okay. Oh, no, come on. Visceral afferents. So when we're talking about pain from an organ, we are talking about the visceral afferents right here. So, so when we're talking about the afferents, is the sensory, motor, of course, is efferent. So exiting the spinal cord versus entering the spinal cord. And so somatic is pain, temperature, touch, pressure, proprioception, and visceral is distension, ischemia, inflammation. So when you do that pain with the appendicitis, what you're doing is you're essentially aggravating the organ, and that's what you're feeling there. Yeah, you guys are getting this one too. So you do need to understand where different cell bodies are located in the nervous system. And then it's going to be a little different for parasympathetic versus sympathetic if you're talking about the efferents. So just make sure you know that. But this is going to be the dorsal root ganglion. And here's why. When you are coming back, all of your efferents are going to come through this dorsal root. And they're going to synapse in this dorsal root ganglion and then send fibers into the spinal cord to ascend. And so please know this. This is where a lot of your questions are going to come from. So you need to know dorsal root versus ventral root. You need to know where things are leaving, where things are coming back, and then where they're going. So is it the extremities? Is it the back? And I don't have it on this slide, but just make sure that you do know where things are going and coming from on here, because there will be a handful of questions from this top left slide and knowing where everything is going. Okay, you guys are doing good on this one too. So it disrupts purine synthesis. And so that's the first thing you need to understand, that it's purine versus pyrimidine. So methotrexate is purine by competitive inhibition of dihydrofolate reductase. This is actually one of the drugs that was on our exam this past week. So, yep. But that's just the explanation on your slide. So for this, you do need to know the folate thing. Like this right-hand slide is actually pretty high yield for your exam. So make sure that you know everything that inhibits at different points. This was also on our exam this past week. So no, it doesn't go away. Yeah, you guys are getting this. So A and B equal efficacy. Efficacy is magnitude. So it's basically the effect you get of the drug when it's taken. And then potency is how much of that drug do you have to take to get a certain effect. Or so be able to manipulate this, know all those enzyme graphs. Unfortunately, that's pretty high yield. So know all of those enzyme graphs. That's very important. Yeah, you guys are getting this one too. So it potentiates the effects of the beta-2 receptor. And so albuterol is a beta-2 agonist. You need to know the definition of the agonist. It just potentiates the effects of whatever that drug acts on. And so since this acts on the beta-2 receptor, it's going to potentiate the effects of the beta-2 receptor. So it's going to bind that and just kind of do what the beta-2 receptor does. Whereas the antagonist is going to, it doesn't bind to the receptor and reverse the action. What it does is just really blocks whatever's going on. And so, not whatever's going on, it's going to block what is supposed to bind there. So that's what it does. So those are the definitions. For those that will be on the island in August, this is my favorite. Dodgy Dock on Wednesday nights. It is my favorite. You have live music and local vendors for all the good food. Oh, I'm so excited to go back. They apparently just a couple weeks ago started back up at Dodgy Dock. And I sincerely hope that the band is the same because he was fantastic. It was so much fun. But yeah, all of you guys are getting this one. They love the grapefruit example because this is classically, they'll tell you this, like a physician will tell you this, you need to avoid certain things if you're taking certain drugs. And so grapefruit is one of those things. So it's inhibition of cytochrome P450. Cytochrome P450 is going to do the metabolism. And so if you inhibit metabolism, you're going to have that product in your body for longer periods of time. And so in this example, you stay inebriated longer because you're not metabolizing out the alcohol in your body. So that is the example. Please know all of the examples that they give you. They give you about 4 or 5 for each, but please know the examples for each. It's not going to be very many questions on your exam, but it's an easy question on your exam and you're going to kick yourself if you don't get it. So make sure you know them. No, I wouldn't say that.
It depends what you're drinking, I think.
Yeah. That's funny. So there are kind of 2 ways to answer this question. ASA is ASA for those that is aspirin. Oh my God, Lindsay. Aspirin, that's the abbreviation. There are kind of 2 ways you can look at this. Brady kind of said one of them is just kind of the easier way, and then there's the going through the chart. But the answer is that it's going to be absorbed in the stomach in the protonated form. And the first way, of course, a weak acid is going to be absorbed when the environment is acidic, or you can use the handy dandy chart. So if you look here, pKa is 3.5. And so the stomach is 2.5. And so 2.5 minus 3.5 is -1. And so if you look over here, 10% is going to be unprotonated, 90% is going to be protonated. And so the protonated form, acid, that's how it's going to be in the stomach. You kind of have to go through all of these to know. So since this is a weak organic acid, it has to be in the protonated form. And so you're just looking for the example in the stomach, or the example that is going to be the most soluble, where it's going to be absorbed. And so acid, protonated, and then it's 2.5. So that is all I had for you. Just a few quick questions. I know we've been going at it for a long time today. But good luck on your exam. Finishing the first module is always really exciting. I remember the time we got done with FTM, I just wanted to be done with FTM. I didn't even care. I just needed to not be in that module anymore, honestly. Then you move on to a little more like body medicine stuff, I guess.
Yeah, we'll cross that bridge when we get there. We'll help y'all get through it. So just look, trust yourself. Go with your first answer. Don't change it unless you're sure you're wrong.
Yeah,
you know more than you think you do. Okay, so sometimes your first answer is the best answer. So let us know if y'all need anything, and good luck. We'll be here with you guys for the next, well, till y'all finish. So, and we'll see y'all down on the island. We do accept alcoholic beverages as forms of payment. So we'll keep that in mind.
And coffee.
Yeah, I'm in New Orleans. Yeah, that's where I live. Yeah.
You guys awesome. Thank you.
Wait, man, I'm in New Orleans too, man. We're gonna have to. I'll get you your drink early.
Let's get it. Come on, let's go. All right, man.
Thank you.
Yeah, no worries. I'm gonna go ahead and stop the recording.
Go fund me.
All right, guys. Good luck.